event. So first of all, I'd love to extend a very warm and hearty welcome to each one of you. So a very good morning, and we are now all set to start the event. So first of all, we are here to celebrate and discuss some of the scientific details for the day 2 at 32nd PEDICON in Bihar for the year 2023. Yesterday we had a lot of discussion and we had a lot of scientific sessions and we could get a lot of information as well. So right now we are going to start the event, and the first speaker is going to be Dr. Madhu Sinha, and we are going to discuss on the role of vitamin D in pediatric infection and immune function. So to chair this session, I'd like to invite Dr. Nishant, who is Assistant Professor in the Department of Pediatric at DMCH. So Dr. Nishant is requested to please join to chair this session. And then I'd also like to invite Dr. Shiv Bachan Singh. At present, he is the director of Shiv Hospital at Shiv Shishu Hospital, Gaya, and also the president for 2023. So, can we have sir on the stage as a chairperson? Thank you so much. And as already have mentioned, we are going to discuss for the role of vitamin D in pediatric infection and immune function. This is our topic, and to speak on this topic and to give a presentation, detailed presentation, I'd like to invite Dr. Madhu Sinha ma'am on stage, who also has received the Academic Excellence Award for the year 2023 in this summit only. So can we have a huge round of applause for ma'am? And I'd like to request our Board of Chairpersons to please give us a brief introduction about Dr. Madhu Sinha ma'am. Mike. Check. Check, check. Check, check.
A very healthy good morning to all of you. Dr. Madhu Sinha ma'am did her MBBS from prestigious Rajendra Medical College, Ranchi. She is of 1991 batch. She did her MD from Patna Medical College, 1997. She has a vast 26 years of experience. She is currently holds Honorary Secretary IAP Bihar, and she was past Honorary Secretary NNF Bihar also. She has n number of multiple journal publication in international level and national level per se. And she has contributed services in various health camps organized by different NGOs. And she is also convener of Pediatric Nephrology Conference organized by ISN Con East Zone 2023. She's a terrific speaker, and she will enlighten this auditorium with her wonderful speech. So
I request Dr. Madhu to continue with his speech.
Thank you, chairpersons. Thank you, Dr. Nishant and Shiv Bachan Singh, to be my chairpersons. And I thank Dr. Nishant for speaking all these present here. We are very thankful to all the people. So first of all, I want to thank the organizing team comprising of Ken Mishra sir, then Dr. Ashok sir, Dr. Salim, Dr. Jha, Dr. Amrita of course, and everyone who is there in the team. They gave me this opportunity as well as also for providing me the Academic Excellence Award. So I'm very much thankful to all of them, and of course to my President IEP Bihar, Dr. Shiv Bachan Singh sir, who always cooperated me to do the works very peacefully. Thank you very much. So now we switch over to the this topic proper. So today I'm going to talk about role of vitamin D in pediatric infections and immune functions. So since long we are seeing that for decades it has been proved that vitamin D is having a very important role in skeletal and dental health. So that is known for years. But recently now we are seeing that so many diseases, they are being associated with vitamin D deficiency like cardiovascular diseases, hypertension, then type 2 diabetes, autoimmune diseases, so many cancers. And that forces us to think about a role of this vitamin D as an immune modulator. So that is the main part which we are going to talk about. So this is a disclaimer from the sponsors because this CME, my talk has been sponsored by Sanofi people. So they are putting the disclaimer that role of vitamin D in pediatric infections and immune functions. And this topic is for discussion and for educational purposes only. And RMPs are requested to refer the full prescribing information under prescribing any product. And if any names has been taken, that is just for illustration purpose. Any resemblance to any person living or dead is purely coincidental. Now, about the skeletal health, we know since long that vitamin D is having a very important role. But of course, vitamin D is required along with calcium for a good bone health. And it is required for calcium absorption, and active form is required for gut absorption as well as for reabsorption in the bones. So the whole, this whole chart I'm not going to read, but you all know that the precursor of vitamin D, it is there in skin or it is coming from the dietary source. And dietary source, you all know that it is contributing very poorly, hardly 20-25%, and mainly we are getting from supplements or from the sun exposure. But I'm afraid to say that nowadays we are hardly getting any sun exposure of the of parents, patients, or ourselves also. And many a times I'm surprised to hear that the parents who are coming to my clinic, they will say that I didn't get my child admitted in that particular school because the school was very good, teaching was very good, but the only thing was that the school is not an AC school. So this is the scenario. We are hardly exposing ourselves to sun, and that's why the deficiency is increasing and we have to take regular supplements. That is my thought. So this precursor of vitamin D after sun exposure, it is converted to vitamin D, and that in liver it is converted by 25 hydroxylation. It is converted to 25 cholecalciferol, and then in liver after action of 1 alpha hydroxylase, it is converted to 125 dihydroxycholecalciferol, and that is the active form, and that is taking part in so many immune modulation actions. Now, who are at risk? Then breastfed infants who are not given vitamin D supplements, and infants born to women with vitamin D deficiency, and children living in areas with low sunlight. That's why nowadays I think routinely we are supplementing each and every infant starting from the newborn period till 1 year of age with 400 units of vitamin D, and many a times we are extending it till adolescents if they are found deficient, and some of the recommendations are even to give it routinely to all the adolescents because even they are being found nowadays deficient with vitamin D. Doses is, you all know, 400 for children below 1 year of age, and after that it is 600 international units. For rickets, we give higher doses. Oral dosing does do. So we are giving 2,000 to 4,000 units per day for several months based on the age of the child. And even previously we were giving injectable vitamin D only, and it was present in 3 lakhs and 6 lakhs units. But nowadays hardly we need them, and we are supplementing only with oral vitamin D, and that works very well. About regarding the levels of vitamin D, then if the level is more than 50, then we call it as sufficient, the unit being nanomoles per liter, And if it is between 30 to 50, then we call the child or anyone deficient. And if it is less than 30, then it is insufficient. So we always want to maintain this level above, at least above 30. But today, if you get the estimations done for the children, you usually will get the levels. Many a times I'm seeing 6, 7, 8 such readings the children are having. So most of the children, and what to talk of children, even the doctors, if they are getting their estimations done, the levels are usually very low. Now, this was about the bone health. Now, switching the gears, now we start talking about the immune modulation role of vitamin D. So nowadays it is being seen that vitamin D receptor, it is almost present in all the immune cells, like lymphocytes, monocytes, macrophages, dendritic cells, to name a few. And there the vitamin D binding occurs, and they work in tandem to cause immune regulation. And these various infectious diseases are helped in fighting as well as preventing autoimmune diseases. So you all know there are two types of passages. We have Th1 and Th17 acting in tandem, and then we have Th2 pathway. So they are helping the Th2 pathway, but inhibiting this Th1 and Th17 pathway. So all the pro-inflammatory cytokines, they are inhibited, like interleukin 4, 5, 10, TGF-beta, they are being inhibited, but at the same time, they are promoting the growth of these anti-inflammatory cytokines. So in that way it works. So for infection, it is beneficial because it is helping in the working of innate immunity, and in that way it helps it as an anti-infectious agent. And by inhibiting this Th1 and Th17 pathway, it causes inhibition of occurrence of autoimmune diseases. So in that way, it is proving as beneficial for us. Now, expression of vitamin D receptor increases after interaction between monocytes, macrophages, and bacterial lipopolysaccharides. Just now I was telling. So the increased vitamin D enables the destruction of several bacteria by acting through helping the innate immunity, and it inhibits the adaptive immunity, and that's why it is causing inhibition of occurrence of autoimmune diseases. And that's why it is seen that African Americans are more susceptible to infectious diseases such as tuberculosis due to high rate of vitamin D deficiency compared to the white Americans. So you all would agree long back when, I want to quote an example about tuberculosis patients long back. I think when we were not born, there were no anti-tuberculous drugs. Then patients were put in sanatorium in open areas with high exposure to sunlight. And that could be the reason which was there in their mind, that vitamin D may cause inhibition of the Mycobacterium tuberculosis growth. And I think people were wise enough at that time also to think on that pathway. Of course, the things have become more clear by more researches. Coming to role of vitamin D in respiratory infections, this various studies has been done, and it has been seen that vitamin D induces production of cathelicidin, an antimicrobial peptide, and low vitamin D increases inflammation and reduces its bacterial activity. That is also by promoting innate immunity and causing inhibition of Th1 and Th17 pathways. An inadequate therapeutic response, that is hypoxia, was reported in children with severe pneumonia and rickets, particularly those with vitamin D deficiency, including a possible role of vitamin D in infectious diseases. So a randomized study was done in 247 Mongolian children, and children took fortified milk with 300 units of vitamin D supplementation, and it reduced the risk of acute respiratory infections by half during the winter and increased vitamin D levels, p-value being 0.047, that is clinically significant. An inverse association between vitamin D levels and severity of illness has been seen. This is another study, And it was done by Madden K. et al. To assess vitamin D deficiency and factors affecting vitamin D deficiency in critically ill children admitted to the PICU. And results were seen as decreased vitamin D levels in patients with severe septic shock and patients receiving vasopressors and high CV SOFA scores had remarkably lower vitamin D levels. So this also shows that if the patient is maintaining a good level of vitamin D, then it helps the patient coming out of PICU or NICU. Low vitamin D levels can expose children to respiratory infections. So higher incidence of LRTI is reported during the winter due to reduced ultraviolet light exposure, but nowadays we are seeing more and more cases of allergic and autoimmune diseases even occurring during winter because hardly people are exposing themselves to sunshine. And vitamin D levels are positively correlated with WBC and lymphocyte counts and negatively with duration of hospital stay. Children with low levels of vitamin D and acute LRTI are at high risk of ICU admission, mechanical ventilation, and MODS. So we should try to maintain a good level of vitamin D even in these admitted patients, and levels should be done at frequent intervals during admission also. Low vitamin D levels can expose children to respiratory infections. Various studies have been done. I'm not going to read the whole list, but the conclusion is children with vitamin D deficiency are likely to develop respiratory infections. Now, vitamin D levels are negatively correlated with recurrent episodes of tonsillitis and tonsillar enlargement. Given the recurrent sore throat infections in children, chronic tonsillitis may necessitate repeated hospitalization, though nowadays we are hardly needing this thing. And the most common reason for tonsillectomies is chronic tonsillitis, which is associated with severe morbidity and infertility in rare cases. This is another study done to measure vitamin D levels in chronic tonsillitis to determine the relationship between vitamin D deficiency and chronic tonsillitis in children. So the conclusion of the study is, I'm having less time, so going very fast, vitamin D levels were significantly lower in patients with tonsillitis based on the number of recurrent episodes, and larger tonsil sizes were inversely correlated with vitamin D levels. Co-administration of supplementary vitamin D and conventional treatment for the management of acute otitis media, another study done for acute otitis media. And the conclusion of the study was, there was co-administration of supplementary vitamin D and conventional treatment for the management of acute otitis media. And conclusion was, vitamin D deficiency plays a major role in immunomodulation and contributes to the risk of UITIs such as otitis media, which may be corrected with co-administration of supplementary vitamin D together with conventional treatments. It's not moving. Slide move नहीं कर रहा था. So this is about role of vitamin D in children with recurrent tonsillitis, and conclusion being recurrent tonsillopharyngitis is associated with low serum vitamin D levels. Coming to maternal vitamin D status and immunity in children, presence of infections is a significant predictor of mortality and morbidity among infants. And so it has been seen that presence of early onset sepsis, significantly lower vitamin D levels in newborns with early onset sepsis, and elevated sepsis markers. There is remarkable inverse correlation between vitamin D levels and all sepsis markers. So nowadays even the mothers are being supplemented, these pregnant mothers, they are also being supplemented with this vitamin. Coming to maternal vitamin D status and immunity in children, another study done. Conclusion was recurrent tonsillopharyngitis is associated with low serum vitamin D levels. This is about UTI, another study done, not having time to read all the studies. Vitamin D deficiency may be a significant risk factor for UTI in children. Relationship between vitamin D levels and asthma in children, this is very important. Vitamin D levels are associated with fetal lung and immune system development. And a series of studies has been done, and this level of vitamin D has been seen to be negatively correlated with occurrence of asthma in children. And even I myself, when I'm getting children with asthma, if they come with, if they're taking the inhalation therapy, but not doing well, then I supplement them with vitamin D, and I've seen personally in so many patients, the patients are doing very well if you, once you supplement the patient with vitamin D along with the inhalation therapy. So that is the message. Another study done for proving role of vitamin D in asthma. So low levels of vitamin D at birth were associated with higher airway resistance in childhood. And according to another study, vitamin D supplementation during pregnancy and infancy reduces the proportion of children sensitized to house mites at 18 months of age. So, last slide. So just to conclude, several clinical studies which has been shown there, of course, I'm afraid I couldn't show because of lack of time, and they have indicated a connection between vitamin D infections and immune function in the pediatric population, and vitamin D supplementation may have a significant role in potential interventions and adjuvant therapies in the management of these patients. Thank you very much.
Thank you, Dr. Madhu, for your nice talk on vitamin D deficiency. We have known that vitamin D deficiency is common, not only in children, but also in mothers. So maternal vitamin D supplementation has been recommended. But we are supplementing vitamin D, but you should be, or you must be conscious about hypervitaminosis D. So that is also dangerous. So you have to estimate the vitamin D and find out it is not increasing the highest level of more than 100. That is all. So thank you again for nice talk. I don't think any question from audience. No. So question you can ask in lunchtime.
Everyone is speechless for due to her excellent speech. So there is no questions. Let us proceed to the rear side of the hall to receive memento. Thank you, sir. Ex-professor and head, PMC, dono.
Thank you so much, everyone. And now, moving to the next session, we are going to discuss about the nutritional care in adolescent girls. So as it is a very important topic, we are going to cover this as our next topic. And to chair this session, firstly, I would like to invite Dr. A.K. Jaiswal, who is the ex-professor in PMCH, ex-professor and also the head in PMCH. So all the ladies and gentlemen, please put your hands together to welcome Dr. A.K. Jaiswal. He was also the speaker yesterday, and he covered a very important topic yesterday. So thank you so much, sir. And then also I'd like to invite Dr. Nigam Prakash Narayan, who is the ex-professor and head of Department of Pediatrics. So these are our chairmen. And then I'd like to invite our speaker on the same topic, Dr. Anil Tiwari, sir. And
Dr. Anil Tiwari is fortunate enough to speak in front of so many legendary persons, who happens to be teacher of mine also. Thank you very much.
wow. So we have such important people, and in fact everybody is so intelligent, so I cannot distinguish, but the teachers, they really matter. So it's very, it's a very thing of sheer pleasure and privilege for me as well to speak in front of you people. So I'd like to invite Dr. Anil Tiwari, sir, to speak on the topic nutritional care in adolescent girls. And before that, I'd like to request the chairpersons to please give us a brief about Dr. Sir.
So, good morning to all, and thanks again to the organizers for inviting us and give the opportunity to chair the session here with, of course, the legendary person, Professor Dr. Nigam Prakash Nayan. And regarding Dr. Anil Tiwari, he has been associated with me since long, and I know him personally as well as professionally also. So he is presently a very senior teacher in Department of Pediatrics, Patna Medical College, and he is a postgraduate diploma in developmental neurology after doing MD and DCH. He has been the executive member this year only, Central IEP, and is the East Zone Coordinator, your Life Beyond Pediatrics module of CIAP, Secretary General of East Zone Academy of Pediatrics 2022 and 2023. He is the ex-Secretary General NNFBR 2022 and 21 and got Best State Chapter Award by NNF India in Bangalore conference in December 2021. He has been the executive editor of the Journal of Practical Neonatology, and he is the editor SAM Info, that is a quarterly bulletin coming from the Center of Excellence from Patna Medical College, and he is a contributor in FIMNC guidelines chapter in textbook of pediatrics in, that is in press already, and he is the associate professor of pediatrics Patna Medical College presently, about 30 publications in national and international journal. He is a peer review works for more than 40 articles, and he is a MCI NMC inspector for various colleges and the various hospitals, and your examiner for DNB Pediatrics and MBBS of various universities. He has been the recipient of East Zone Pioneer Award, very prestigious award. So that was a brief introduction for Dr. Tiwari. I will request Professor Dr. Nigam to brief about the present topic.
Thank you, Dr. Jaiswal. In fact, over and above all the introductions which has been rendered right now, एक ऐसा सौम्य व्यक्तित्व है अनिल तिवारी जो हर एचओडी के फेवरेट बने हुए हैं आज तक जो फ्रॉम संजाता राय चौधरी माई सेल्फ नीलम वर्मा ए.के. जायसवाल जो भी एचओडी आया उसके सबसे नंबर 1 चहेते आदमी ये डॉक्टर अनिल कुमार तिवारी रहे ये सबसे बड़ा इनका व्यक्तित्व है और उसके अलावा टुडेज सब्जेक्ट इट्स वंडरफुल I think we are talking about Adi Abadi and we are not taking care of the nutrition of the Adi Abadi. In a, you see, a very male-driven society, still we see that the girls are ignored. I've seen in my practice, you see, the adolescent girls, they are very much ignored, whereas the boys are very much cared. So this is a typical society. Bihar itself is a witness to it, and I think over the whole other states also, this is the problem. So I think the subject is quite relevant today, nutritional care of adolescent girls. And I'm sure that someone like nutritionist like Dr. Anil Tiwari will throw a wonderful light today. Dr. Anil Tiwari, please.
Thank you, sir. Thanks. My both chairpersons, and I am thankful to the organizing team of Darbhanga for inviting me here. And especially at this moment, I am very much thankful to Ashok sir कि आप दोनों गुरुओं को मेरा chairperson बनाया. बहुत बहुत धन्यवाद. The topic was suggested by the president of nutritional chapter of IAP, Dr. Praveen, who asked me to tell something about this topic because it is very neglected topic and it is a topic to be addressed in a significant way as much as possible. So the biopsychosocial perspective is fast changing, so fast changing that when we go to literature search for more than 100 years, it has been observation that the age of puberty is so fastly decreasing in girls that हम लोग क्या कहते हैं कि लड़कियां झट से जवान हो गई, फटाफट जवान हो गई. So that is the changing biopsychosocial perspective. And what is the implication of this? कि इन लोग को न्यूट्रिशन प्रॉपर जितना मिलना चाहिए नहीं मिल पाता है, और ये एक माल नरिश्ड या अंडर नरिश्ड जो एडोलेसेंट गर्ल है वो एडोलेसेंट माँ बनती है और लो बर्थ वेट बेबीज पैदा करती है, और ये विशेष सर्किल चलते चला आ रहा है. सो दिस इज वेरी इंपॉर्टेंट टॉपिक एंड वी हैव टू एड्रेस इट, एंड ओनली not the pediatricians are concerned, but also it has got the importance in many newspapers of country. One is here example, The Hindu, on June 12, 2023, it has a very good publication regarding this. When we go for literature in so many journals, it has been very importantly placed everywhere. And the National Library of Medicine, one paper shows that well-nourished adolescent girls in the school stay longer, achieve better learning outcomes, delay their marriage and first pregnancy, multiply their life options, and advance their families and nation's development. So important. Nutrition International mentions that with good nutrition, 600 million adolescent girls can break the cycle of malnutrition and poverty. Well-nourished girls with access to education learn better, earn more over their lifetimes, and can better contribute to their families, communities, and countries. So with this perspective, we are moving ahead. Let us have a look on the health indicators of adolescent girls. You can see that women in the age group of 15 to 19 years who are already mothers at the time of survey, the data is 6.8, that is around 7%. That is a very significant data, because teenage mothers problem is so much important. Regarding adolescent fertility rate in the age of 15 to 19 years, the figure is 43. Anemic population, all of know around 60%, and even the use of tobacco and alcohol is also very alarming. So, why nutrition is essential? Because any nutritional deficiency experienced during the critical period of patient life can have an effect on the future health of individual and their offspring. Failure to consume an adequate diet at this time can result in delayed sexual maturation and delayed or retarded physical growth. The rapid physical changes during adolescence have a direct influence on person's nutritional needs. Adolescent period is the last chance of nutritional rehabilitation and prevention of future risks like growth failure, psychosocial problems, low birth weight babies, and etc. All of us know that the fastest growth occurs in the first year of life, and after that it is the only in this age group that the fastest growth is there, and it is the last chance we can get to address the problem. Most of the adolescent girls fail to achieve full endowed genetic potential for growth and intelligence due to suboptimal interaction of host factors with nutrition and environment. High prevalence of low birth weight babies and adolescent growth failure are indicators of social deprivation. So we can judge how many low birth weight babies are being taking birth. Why malnutrition, along with other factors such as poverty, gender barrier, and social and cultural norms, contribute to about 130 million girls being out of school. Even when girls are in school, anemia can hold them back from academic achievement and potential future economic empowerment. Girls who do not attend school also face a high risk of pregnancy, early marriage, and are more likely to give birth to smaller infants, perpetuating the intergeneration cycle of undernutrition. Pregnancy and childbirth related complications are leading cause of death for girls in the age group of 15 to 19 years. So how undernutrition is going to affect the adolescent girl? It affects by their ability to learn and work at maximum productivity, increasing the risk of poor obstetrics outcome for teen mothers, arresting the healthy development of future children, affecting sexual maturation and growth, preventing the attainment of normal bone strength and the development of healthy teeth if a youth does not get enough calcium. And what is more worrying is the persistence of negative effect of adolescent malnutrition throughout a woman's reproductive life. That is the very sad part, that this effect persists throughout the woman's life. Literature scan on adolescent growth reveals that the 50th centile, this point should also be in the mind of all of us, that the 50th centile height and weight of Indian child corresponds to 50th centile of National Center for Health Statistics, but it slips down to 10th to 20th percentile by the age when the baby is reaching to 10th year of age. So that is a very significant point at which we fail to take corrective action in between these age group. We are going to lose everywhere. So this picture has been taken from ACC, SCN appointed Commission on Nutrition Challenge. It shows that low birth weight babies grow to a stunted child, then a stunted adolescent, and pregnancy with low birth weight babies, women malnourished, again producing. So we have to act faster at the right moment of life to break this vicious cycle. So how can we achieve this? All of us know that it can be achieved by balanced diet. Already yesterday and also it will be discussed today only. Professor Jaiswal sir has said much about the micronutrients. Also we know about macronutrient. So what is balanced diet? A balanced diet is one which supplies all the nutrients with the right quantity and proportion. It is essential for growth, to maintain good growth and to prevent deficiency. Nutrients for anyone, including adolescent girls, must contain all macronutrients and micronutrients. As adolescence is a rapid growth period, some nutrients, especially protein, fat, iron, calcium, zinc, folic acid, apart from iodine and vitamin A, are of special importance. So all of us know these are the components of balanced diet. Lastly, it has been written fibers and water, which is very important to maintain a good health. So an adolescent girl needs about 2200 kilocalorie, with carbohydrate about 16%, fat about 13%, constituting the amount diet, and protein about 10 to 15%. So energy needs of adolescents are influenced by anyone, including adolescent girl, by activity level, basal metabolic rate, and increased requirement to support pivotal growth and development. Adolescents need additional energy for growth and activity. Adolescent girls needs approximately 22 kilocalories, about 400 more kilocalories than a child each day. So that is to be kept in mind that बहुत छोटी अवधि है बच्चा से एडोलेसेंट होने में, और रिक्वायरमेंट कितना बढ़ रहा है 400 किलो कैलोरी. यदि इसको हम नहीं सप्लीमेंट करेंगे तो वी विल लैक एवरीवेयर. So this plate has been designed by ICMR, and we can observe this beautiful plate that how the food diversity is going to help. It must be substituted with the glass of curd or glass of milk outside, and 50% of the diet should come from vegetable source and rest from animal source or carbohydrate, nuts, goods, fats, oil, etc. So if we maintain the food diversity, then we can get all the nutrients supplied by the nature. So why food diversity? Already discussed yesterday by Professor Jaiswal sir that no food or nutrition supplement can provide so many micronutrients, bioactive compounds, antioxidants together as the diversified food items. The plate typically illustrates proportion of foods from different food groups to be sourced for a 2000 kilocalorie Indian diet. Experts recommend sourcing of micronutrients and macronutrients from minimum of 8 food groups per day. Vegetables, fruits, green leafy vegetables forming essentially half of the plate of the recommended foods per day. The other major portion is occupied by cereals and millets, followed by pulses, milk and curd. So, I will not go in detail about protein and other minerals and vitamins. Protein is important for growth and maintenance of muscles, and it should be supplemented in proper way and with good protein. All of you know that non-based source is the main supply of good protein, but also legumes, beans and nuts are also very good supply source of proteins. Regarding fats, Australian dietary guidelines for children and adolescents recommend 25% of total energy as fat, with less than 10% of energy from saturated fat for children aged over 15 years. The type of fat rather than its quantity is more important in determining the health consequences of dietary fat. Iron is also very important micronutrient, and its requirement is increased not only by the onset of menstruation, but also it has a role in the gaining of muscle mass and other metabolic activities. Calcium is very important and its needs must addressed because it is estimated that 45% of peak bone mass is attained during adolescence, and so adequate calcium intake is important for the development of dense bone mass and the reduction of the lifetime risks of fracture and osteoporosis. Additionally, calcium needs during adolescence are greater than they are in either childhood or adulthood because of the increased demand for skeletal growth. In order to get the required 600 to 1200 milligram of calcium, teens are encouraged to consume 3 to 4 servings of calcium-rich foods each day. यहाँ ये दिक्कत होती है कि मिल्क हमारा जो है डेयरी प्रोडक्ट्स गुड सोर्स है और उसके बारे में बहुत सा मिसकंसेप्शंस है कि हम दूध पिएंगे, फैट खाएंगे, मोटे हो जाएंगे. So this needs counseling, and facts should come in the mind of the adolescent girls that you can modify it as per the need of your choice. So girls preoccupied with body shape might have a dilemma of including calcium-rich dietary foods which they perceive as fattening agents. The nutritional survey carried out by various agencies worldwide found 56 to 60% of girls aged 9 to 13 years did not meet the recommended dietary intake of calcium. As dairy products are good source for calcium, the fear of getting fat through the consumption of dairy foods is always a matter of concern, particularly in adolescent girls. Zinc is also very important mineral. It's second most abundant trace mineral, and it is very recommended. Similar is folate and iodine and vitamin A. In vitamin A, I will like to highlight that vitamin A deficiency state is a condition where tissue concentration of vitamin A is low enough to have adverse health consequences, but there is no evidence of clinical deficiency. So this needs to be addressed, and we must go for vitamin A supplementation at regular interval. So current advances for macronutrient nutrition, these are the methods for beautifying, fortifying everything for the micronutrients and macronutrients. That's a food fortification, already discussed by Professor Jaiswal yesterday. Dietary diversification, already discussed that food groups of at least 8 food groups should be included in your diet. Increased consumption. So adequately available fat, protein, everything should be present to the Next, we have the concern about healthy eating practices and something about rainbow revolution. So food propagation, I am going to omit here side. Rainbow revolution. So there are so many things you can see how to go for revoluting everything. Government has taken all the steps for food grains, milk, oil seeds, fisheries, fruits, how to go for good source and enriching the ingredient everywhere. So some food habits of concern in adolescent girls, they easily skip breakfast, increase food from other groups they consume, increase food outside home they consume, and they have preference for soft drink. So how to go for healthy breakfast? Because breakfast is considered brain food, improves performance in studies, breakfast improves physical activity, does not contribute in overweight, keeps healthy, and skipping breakfast leads to obesity and overall poor development. We can make junk food into healthy breakfast by such a simple maneuvers. Add more fresh fruits, sprouted grains, beans and nuts in daily breakfast. Use paneer in place of cheese. Have low calorie and low fat diet and have skimmed milk. So there are some potential nutritional related problems and obesity is one. So for this, aerobic exercise must be done for a half hour to 1 hour per day. We should junk the junk foods in one line. Coming to other important topic, what should be the policy options? So adolescent girls need access to information and services related to nutrition, reproductive health, family planning and general health. Programs can reach girls through a variety of avenues including schools, workplace, marriage registration system and youth-oriented health programs. Schools can be a key part in helping adolescent girls to become healthy adults. Researchers show that promoting female education and literacy can improve nutrition and encourage females to seek regular health care. Teaching girls to use their knowledge of nutrition when preparing and handling food can improve their health and that of their families. In communities where many adolescent girls are underweight, supplements may improve girls' overall health and their pregnancy outcomes, including reducing their risk of bearing low birth weight babies. In India and Egypt, for example, where iron supplements have been given out in schools, the prevalence of anemia has fallen significantly. Interventions that reach adolescents help establish healthy habits that continue into adulthood. Such programs should also reach to male boys who receive information about women's increased nutritional requirements during pregnancy and lactation may be better partners when they form families. So some useful tips, nutritional requirements of growing adolescent girls require them to eat 3 regular meals a day with some snacks in between. Skipping meals will lead to deficiency of vitamins, minerals and carbohydrates, which in turn lead to lack of energy and difficulty in concentration. Adolescent girls need iron-rich foods to compensate for monthly period loss. Foods like meat, fish, green leafy vegetables, pulses, lentils, nuts, seeds are good sources of iron. Eating an adequate amount of food at breakfast improves memory and concentration in school. Breakfast is the most important meal of the day and hence should not be skipped. And girls who eat breakfast regularly tend to have a healthier weight gain than who skip it. It should be made known to everyone. So last slide, take home message. Nutrition in adolescent girl is a neglected subject. During adolescence, girls must get proper balanced food with proper food diversity, taking care of vitamins and micronutrients to break the vicious circle of malnourished adolescent girls, mothers, expectant mother, low birth weight, higher baby, higher maternal and child mortality. With minor modifications, unhealthy foods can be made healthy. Proper communication related to nutrition, reproductive health, family planning, and general health should be provided at every contact point with adolescent girls. So thank you very much.
Thank you, Dr. Tiwari, for your excellent deliberation about the very, very important and neglected subject. And you very rightly mentioned that it has got a intergenerational effect, because the adolescent girl finally, after marriage, she will conceive and she will give the birth. If she gives the birth to a female child, that to a low birth weight child, again the neglected female child and adolescent girl, and marrying again and conceiving again, and the intergenerational effect. And that leads to, of course, neonatal mortality and the later morbidities in the childhood. So thank you again for your brilliance. And any questions or any doubts? Dr. Nigam, probably.
Yeah, I think it was a wonderful deliberation by you, but I am sure that it affects the child mortality as well. The
Yes, sir.
adolescent, yeah. But one thing which I found in your slide, I mean, I have got a little reservation that only 10 to 15 milligrams supplementation of iron will do, because if you see, there is a lot of anemia in our community. And I think this should be revised. This, I mean, whatever advocacy was there, 10 to 15 milligram of iron is very little iron. I mean, you have to increase. At least 1 milligram per kg per day must be there, at least. So
Okay,
that
sir,
was
I will-
only
I will
thing
see.
which I noticed.
I will see. I will check it.
Yeah, it is only 10 to 15 milligram, which is very minuscule amount. So I think otherwise everything slide was very, very important for each one of us. Thank you very much.
Thank you, sir.
Very
Thank you.
common among the adolescent girls. Thank you again, Dr. Tiwari.
Thank you, sir. Thank you.
Thank you so much, sir. Now I request the speaker as well as the chairpersons to move to the rear side of this auditorium to collect the mementos. And the next topic is pediatric endocrinology in office practices. This is going to be our next important topic. And to chair this session, first of all, I'd like to invite Dr. Ashit Kumar, who is Assistant Professor at Katihar Medical College, and also Dr. Ashish Kumar Bhartiya, who is Associate Professor at Katihar Medical College. So I'd like to invite both of them on stage to chair this session, and also Dr. Arvind Jha, who is the organizing treasurer for 32nd Bihar PEDICON 2023, also the director and chief consultant, Dr. Arvind's Aram Emergency Newborn Care and Pediatric Specialities. So all the three chairpersons are already seated on the stage. So would now like to invite the next speaker, Dr. Amit Kumar, to speak on the same topic, pediatric endocrinology in office practices. So doctor is already here, so I'd like to request the chairpersons to give everyone a brief about Dr. Saab. Thank you.
First of all, I'd like to say that it's always honor to fortunate to get a chair of session of a person who is actually your teacher. So my actually first teacher is Dr. Amit sir. Dr. Amit Kumar is actually MD Pediatrics, now right now Assistant Professor Pediatrics, IGMS Patna. Did his senior residency from the AIMS, New Delhi. Has a particular interest in pediatric endocrinology. Trainer of various IEP module. Trainer of advanced NRP, IAP, ALS, NTEP, NBSU, FNBC, etc. Has worked with UNICEF and Bihar government on many projects for strengthening SNCU service in Bihar. Participated as faculty in many state and national conferences, at present holding the post of treasurer in IAP Bihar. More than 30 publications in national and international journals, reviewer in many journals, associate editor of Bihar Pediatric Journal, 2 chapters in well-reputed books on pediatric ventilation. Received Academic Excellence Award in Bihar Pedicon 2022. So,
one more correction and a big round, big congratulations, Dr. Amit sir. He is now promoted to Associate Professor. Kindly give him a big hand. Sir, please start, sir.
Okay. Thank you, chairpersons, for kind introduction. And I'm happy I can see few postgraduates also. So good. So, why pediatric endocrinology? So the recent data says that there are more than 3 million, that is 30 lakh children and adolescents affected by endocrine disorders in India. And children with short stature, hypothyroidism, pubertal disorders, they actually form a major contribution to day-to-day office practice. So as far as normal practitioner, pediatrician, they are concerned, can they refer every endocrine disorder to a specialist? No. I know that the answer would be no, but still we want best care for the patient, and are there any medical legal issues if we are not referring? So I want to just emphasize is that we all can treat endocrine disorders unless if it's too tough or we want special consultation. So what are the endocrine disorders which we are going to cover? They are hypothyroidism, growth hormone deficiency, and precocious puberty. But the way of teaching today is going to be different. We all learn what are the guidelines, what are the methods of diagnosis, what are the methods of treatment. But you all would agree that we learn most from our mistakes. So one saying that some of the best lessons we ever learn, we learn from our mistakes and failures. So do you know who was Stan Edwards? Even I don't know. But this figure you might be knowing, Warren Buffett. Why? Because he says that it's good to learn from others' mistakes. So why we should commit a mistake when we can learn from others' mistake? And the last, Hippocrates is not going to leave us. Primum non nocere. That is first do no harm. That is the first thing which we have in our minds, that we are not going to harm the patients. So my talk is going to be based on this fact, that first we should try to avoid mistakes, and only then we can do good for the patients. So it's not about guidelines or what is the right thing, but what are the common mistakes which we do day to day as far as practice of endocrinology is concerned. So it would be case-based discussion. And the first case, all very common cases, day-to-day cases, which we see in our practice. So the first case is a 13-year-old boy concerned about short stature. So height is 135 centimeter, weight 30 kg, father's height, mother's height mentioned, which all PGs must consider that they should always take parent's height when working up for the height of a patient. The patient is otherwise active, no developmental delay, no features of any chronic illness. So what you're all going to do next? Answer is simple. You're going to plot it on a growth chart. So this is a growth chart, blue, you know, because the patient is a boy. So what are the parameters which we are going to plot? So simple parameters. We are going to plot the height, the weight, and the mid-parental height, if you can see here. So, and X is the bone age. So clearly you can see that the patient's height is below third centile, so defined as a short stature patient. But the next thing, the Tanner stage, the pubertal stage was 1, and bone age was 10 years. To remind, the patient is of 13 years age. One very important thing for PGs, how we calculate if the MPH, mid-parental height, is 169 centimeter, it doesn't mean that the patient is going to be exactly of that height. So there is a range. We can add plus minus 6 to that height to get a target range. That is 175 to 163 centimeter, and anything in between this is going to be normal. So this is very important. PGs must learn how to calculate height age and weight age. So actually this laser point is not working well. So you can see this is the actual height. And if we draw a horizontal line to the 50th centile of the chart, and where this 50th centile cuts at the age, that is around 9.5 years. This is the height age. It means the patient's height is like this, but he was normal, this height is normal for 9.5 years. So this is how we calculate height age. So next, this thing also you should definitely plot on the growth chart when you're working up for a short stature patient. So as usual, we ordered all basic investigations, CBC, KFT, LFT, tissue transglutaminase to rule out chronic illnesses, thyroid profile, electrolytes, blood sugar, etc. Everything was normal. But in addition, a random growth hormone was also prescribed, which was very low, 0.1 nanogram per ml. So the doctor looking after this patient, knew something about growth hormone therapy, and he advised this. So as all the cases are going to be like faults, so is there anything wrong? You all know this is a very simple case. So the patient went to a pediatric endocrinologist, and growth hormone stimulation after priming was done because the patient was 13 years. We prime with 6 steroids, estrogen or testosterone in girls after 11 years and boys after 13 years. So stimulation test actually revealed that growth hormone were in normal range. The patient was reassured and followed for a few years, and there was normal growth at 17 to 18 years. So what is the diagnosis? It is CDGP, constitutional delay in growth and puberty. So this is very simple. And few takeaway points from this case is that bone age, it's very simple how to calculate bone age. Next time I plan to take a class on bone age. It's very simple how to do it. And actually there's a free Android app available for that. You can download it and you can do it. So bone age, so growth charting on growth charts, bone age, TANF staging, and growth hormone stimulation. It's done by clonidine, ergomin. All teachers, everyone, you are using ergomin day to day for hypertension. So this is what we use for growth hormone stimulation. It's something to know about GH stimulation. It is done in morning, fasting. A baseline sample is collected for growth hormone, cortisol, RBS, and insulin-like growth factor. Then we give ergomin at rate of 5 microgram per kg, and repeated samples are taken. And actually, we have performed more than 20 growth hormone stimulation tests and never have seen any side effects. So the takeaway point is that never treat on the basis of random growth hormone levels. This is a case series which we published about growth hormone disorders. Simple 5 cases. Actually, one SR is working with me day to day only for pediatric endocrinology. So this is for him. And for all teachers, junior teachers, that case series is in an index journal is a valid publication for promotion as per NMC rules. So it's very simple. You can just take few 5-10 cases and publish so that it helps in promotion. So the case 2, now this girl is actually tall, not short. A 7-year-old girl who happens to be tallest in her class comes to a clinic for some mild URTI, and the doctor is very good. He follows the protocol. He charts all anthropometric data on a growth chart. So height is 131 centimeter, weight is 25 kg, and mid-parental height is 160 centimeter. A 7-year-old girl child. So again, pink growth chart because it's a female. So you can see that the height is actually very good, almost at 97th percentile. Weight is okay. And mid-parental height is also on the higher side. So the patient was reassured, told, कोई बात नहीं, बच्ची लंबी है, अच्छा है, आजकल लंबा होना अच्छा है. कुछ miss हुआ क्या यहाँ पे? Was anything missed here? Did we miss anything here? So actually, if you can see, again we plotted, which we always should plot, the height age. So it is for a 7-year-old girl child, height is actually, again we drew a horizontal line towards 50th centile and looked for the age. It corresponds to 9 years. So the height age was 9 years and weight age is okay, 8 years. So what was missed was TANF staging. Actually, 7-year-old girl was having breast stool enlargement, and when we looked for the bone age, it was 12 years. So is there anything to be concerned? The child is tall, bone age is 12 years, so what happens? So what actually happens is that for height age of 9 years, again, just to recapitulate, girl is 7-year-old, the height age is 9 years, but the bone age is 12 years. So that girl child has already lost 3 years of height gain. So, and most probably a cause of central precocious puberty, all know. We define precocious puberty when a girl is having any development of puberty. The first is breast development before 8 years of age. So, though the child is tall for her age at present, the final height may remain lower than a growth potential due to early fusion of bone epiphysis. So this is very important. A tall girl with signs of precocious puberty, you should always look for the bone age and do further analysis, which I will show how simple it is, only this thing I want to show. We all advise like LH, FSH, prolactin, everything. One data, if you can look, that a basal, we do gonadotropin stimulation test also, but simple basal LH level of more than 0.2 IU per liter suggests that the puberty has started. So this value can remember. And if you take cutoff of 0.3, then you are going to be 100% specific that the puberty has started. So in next cases also, I will try to give 1 point which you can take away from here. So never treat on growth hormone, random growth hormone, and a basal LH is very important. So now coming to the case 3, a 12-year-old female child comes to OPD with difficulty in breathing for 2 weeks, slightly sick, but has come to your OPD. And again, you give time to the patient, you have taken a good history. So the patient was also looking short, not gaining height and weight for the last 3 to 4 years. Patient also is looking lethargic, and on history gives that her school performance has decreased over the time. The patient was significantly short for age, but you also find in the examination that the heart sounds are muffled. And vitals are more or less stable, and there are no significant features of CCF. So you had pericardial effusion in your mind because muffled heart sound and breathing difficulty. So the first test, which is readily available at your OPD, you got an X-ray and clearly it shows that there's a pericardial effusion. Okay, so you sent the patient for an echocardiography evaluation, which came to you, and there was diagnosis of moderate pericardial effusion on echocardiography. Simple, but as you have seen that the patient has poor scholastic performance, short height, you also sent with other workup you sent, thyroid profile. This point I want to highlight, dry skin. If you're just going to touch the hand or arm of a hypothyroid patient, I find it very, very good sensitive marker. A dry skin, you can just by touch, you can say that the patient is hypothyroid. I'm trying to also include this in one of my study protocols that can we objectify it. So this is very important. So as expected, we found that the patient is hypothyroid with TSH more than 100 and T3, T4 low. Anti-TPO was more than 1,000. Ultrasound was also done, which showed utopic, diffusely utopic. It was in position, and the thyroid gland was enlarged with micronodular pattern. So diagnosis was very simple: Hashimoto's thyroiditis with moderate pericardial effusion. And as the patient was a bit sick, you immediately started the patient on thyroxine, because by your knowledge, you know that Hashimoto's can cause fluid collection in different spaces, including pericardial effusion, and other measures like lactone for pericardial effusion. But as I'm presenting, so there's going to be definitely going to be a mistake in each the cases. The thyroxine was added in full dose. That is 3 to 5 microgram per kg per day on day 1, considering the severity of the condition. And 3, 4, 5 days after the patient comes to you, that the patient is having tremors, irritability, repeated vomiting, headache, and altered sensoria. A patient who was sick came to you with some other finding, now is having some other features. And they will say that you have done something. So, पहले तो ठीक थी 2-3 महीने से, अभी दवाई दिया, क्या हो गया? So, is there any mistake which the patient was sick, definitely hypothyroid, all reports suggest. So what wrong we have done? So only thing which we have done that there's so much of fluid collection. So this is not an acute hypothyroidism. It is a chronic hypothyroidism. When we see a patient of chronic hypothyroidism, the patient is actually settled on that level of thyroid hormones. So always start thyroxine with 1/4 of the target dose and gradually build the dose over the next 10 to 12 weeks. So if you calculate that the patient requires 100 microgram, so you just start with 25, wait for 2 weeks or 3 weeks, then increase the dose gradually. Otherwise, those features of hyperthyroidism the patient can have that. So just summarizing how you're going to work up a case of acquired hypothyroidism, simple, T3, T4, TSH, anti-TPO, ultrasound, and if any doubt, go for thyroid scan. These 4 tests the initial test you can do with this, and almost all cases would be diagnosed. So coming to case 4, again, 5 minutes more. I have only 2 more cases. 6-year-old male child, gained height normally till 2 to 3 years of life, not gaining height since then. Height is very short, 91 centimeter, weight 13 kg, cherubic faces, that is doll-like faces, and developmentally normal. So it is written on this slide that the patient is having growth hormone deficiency. Normal height till 2 to 3 years and doll-like faces. These two things can lead you to, help you to diagnose growth hormone deficiency. So we did a bone age by TW3, that is Tanner-Whitehouse 3 method, and bone age was significantly delayed. So we worked up this case perfectly. We did a growth hormone deficiency by GH estimation test, and everything was, but you can see that we also did thyroid hormone. FT4 was low, range is this, and TSH was normal. So we again told the patient to have growth hormone supplements because we diagnosed growth hormone deficiency, but he told actually a 10 kg child requires 10,000 rupees per month for growth hormone therapy. So this is costly. So he told, sir, I'm a rickshaw puller, I cannot do this. So the doctor decided कि चलो growth hormone तो मुश्किल है, thyroid FT4 भी तो कम है, वो दे देते हैं, कुछ तो height बढ़ेगा. So it was decided to start thyroxine supplementation at least, and patient was sent home. So what happened? 4 days later, the patient presented to PICU with drowsiness, features of hypotensive shock, and could not be revived despite boluses and inotropes, and patient actually expired, only by giving thyroid supplements. So what happened? What went wrong? This is the learning point which you must have in your mind, that normal TSH, which we saw 0.9, with low T4 or free T4 is not normal. And this is actually true for all endocrinological workup. Cortisol normal hai in stress, that is not normal. Insulin normal hai in hypoglycemia, that is not normal. And T4 normal hai in case of like TSH normal hai in case of low T4, it is not normal. This is deficiency, relative deficiency. So the case must have been a case of multiple pituitary hormone deficiency and was given thyroxine, which increased the metabolism, further decreasing the cortisol store, leading to hypertension and shock. And furthermore, hydrocortisone was not used. So you all PGs should remember that if nothing is working, yesterday Shravan sir also told, always try to give hydrocortisone if nothing is working. So takeaway points, like always think of, whenever you think central hypothyroidism, that is T4 low, TSH low or normal. So it is central hypothyroidism. Always rule out cortisol deficiency. First give cortisol, then thyroxine, then growth hormone. Never thyroxine before cortisol, otherwise patient is going to be in trouble. MRI may be considered. So the last case, case 5, a 12-year-old girl who was shot, vaginal bleeding for 1 year, abdominal distension 3 months, and breast 2 only. Ultrasound abdomen showed bilateral adnexal cystic as well. Sent to a gynecologist for pain abdominal distension, and the gynecologist actually planned for surgical removal of the cyst because the patient was having pain abdomen. So something wrong here? Again, wrong has to be there. So actually there was breast 2, no pubic hair, height was low, weight was low, and you can see height age was very low than the weight age. So short height for height age, less than weight age suggests endocrine causes. You worked up for it, TSH was very high and T4 was low. So it was a case of von Wieck-Grumbeck syndrome. And the beauty of this diagnosis is that it is completely reversible on treatment of hypothyroidism. Just give eltroxin, all cysts will disappear. And many cases have been operated for this. And one thing to remember, the physiological puberty sequence is thelarchy, adrenarchy, and menarchy. If anything, like thelarchy the patient was having, but now this patient was having menarchy, no adrenarchy. So this is not normal puberty. You have to look for something different. So summary, nothing different. Just first try to do no harm to all the patients. Thank you.
Thank you, sir. It's a very well explained, very difficult topic explained in a very simple language, especially for the PG. Thank you, sir. Still a great learning from you.
And I'd like to request all the chairpersons and the speaker to move to the rear side of the hall to collect their respective mementos. And I'd especially like to thank Dr. Amit Kumar for enlightening us with the knowledge on this topic. And then I'd like to move on the next topic, which is the utility of genetics in pediatrics. So how is genetics important for pediatricians? This will be our next topic, and To chair this session, I'd firstly like to invite Dr. S.C. Yadav, who is Assistant Professor at Saharsa Medical College, Dr. Alka Singh, who is the Professor of Pediatrics at NMCH, and also Dr. Chandra Mohan, who is the Professor of Pediatrics at AIMS Patna. So all the chairpersons are firstly requested to kindly join us on board, and then I'd like to request our honorable speaker, Dr. Mayank, to please join us. And again, I'd like to repeat the topic. The topic is utility of genetics in pediatrics, and our keynote speaker is Dr. Mayank. So first of all, I'd like to request all the chairpersons to please introduce everyone in the audience about Dr. Mayank. Thank you so much. Over to chairperson. Thank you.
So I am privileged to introduce Dr. Mayank Nile. He is MD Pediatrics and DM Medical Genetics, Senior Consultant Genomics at Agilus Diagnostic Limited, Consultant Clinical Genetics, Sant Parmanand Hospital, Civil Lines, Delhi. He was Assistant Professor, Department of Medical Genetics, Postgraduate Institute of Child Health, Noida, Assistant Professor, SGPGI, Lucknow, Senior Resident, Pediatrics, MAMC, New Delhi, Registrar, Pediatrics, Cloud9 Hospital, Bangalore. He has 15 research publications in national and international journals. He is a life member of Society of Indian Academy of Medical Genetics, life member, Indian Society of Inborn Errors of Metabolism, and certified member of Society of Fetal Medicine. So he is going to give a deliberation on a very important topic. Nowadays we are depending more and more on genetic analysis of different conditions, and I am sure it is going to benefit everyone.
Thank you, ma'am. At the outset, I would like to thank the organizers for giving me this opportunity. And I'm feeling so much emotional and nostalgic because I did my MD Pediatrics from Darbhanga only. So it's like a homecoming for me. Now, this is a very important topic. Now, why genetics is important for pediatricians? Initially, something which was like rare, it is not that rare because you all know we have a large population, and many of these disorders we are seeing almost daily in our routine practice. Around 10,000 rare genetic disorders are known, and you will be surprised to know that every year new genes and new syndromes are coming up which are affecting multiple dimensions of a child. As per WHO, any disease with a prevalence of less than 1 in per 1,000 population is called rare. But you will be surprised to know again that around 300 million people are suspected to have such disorders, and personally I feel many of them die undiagnosed. And WHO also recommends that genetic services should be introduced in a country when the IMR is less than 50. So our IMR around 27, we need to think seriously about genetic disorders. Now, when we come to genomics in pediatrics practice, various research studies have shown that even if the pediatric admissions which we are doing daily in our emergency, around 15 to 20% of them have some or other genetic etiology. So right now is the time that we pediatricians should be aware about the various genetic disorders, various genetic tests which we are employing daily in our office practice. So what should be the approach in pediatric genetics? Something like a phenotype is very important. Now by phenotype I mean detailed clinical features of the child. As a pediatrician, we all know clinical examination is very important apart from the history. Similarly, it is more important for genetics head-to-toe examination, any dysmorphism, any subtle feature in the general examination or systemic examination, we need to document it. And again, choosing the right test. You should know that there is no single genetic test for all which will cover all the genetic disorders. There are different set of genetic tests which we need to decide as per the etiology. Pre-test counseling is very important. Patient को पता होना चाहिए कि भाई आपका हम whole exome करा रहे हैं, आप कितने पैसे खर्च होंगे, तो उसका outcome क्या होगा. Then only the patient will go for the test or will not go for the test. Generally, we have a non-directive counseling. Patients should also have the right to opt out after knowing the pros and cons. Review of the reports is very important, and most of these genetic disorders require a multidisciplinary team. It is not like that we should not take opinion from our cardiology colleague or our endocrinology colleague. There should be tumor boards, there should be a metabolic board, which is already there in most of the places. Then utility of genomic databases. अगर आपने genetic test कराया होगा exome किसी में तो उसमें genes रहते हैं, variations आते हैं, लगता है भाई ये क्या है. There are some very good, easy, available databases which are free of cost, which we should keep on checking. कोई भी जीन आपको डाउट है आप उसमें डाल के गूगल पे देख लो, जैसे हम लोग फेसबुक करते हैं, व्हाट्सएप करते हैं, सिमिलरली समथिंग लाइक दैट. देन अगेन पोस्ट टेस्ट काउंसलिंग इज वेरी इंपॉर्टेंट टू एक्सप्लेन द आउटकम ऑफ द रिजल्ट. रिवर्स फेनोटाइपिंग, बाय रिवर्स फेनोटाइपिंग आई मीन फॉर एग्जांपल ग्लोबल डेवलपमेंटल डिले का पेशेंट है, आपने एक जूम कराया और थियामिन रिस्पॉन्सिव कोई डिसऑर्डर आया, ठीक है, हमें पहले पता नहीं है, आप उसको रिव्यू करो लिटरेचर, पेशेंट को दोबारा बुलाओ एंड जस्ट मैच द फाइंडिंग्स. मेनी टाइम्स यू विल सी कि सर्टेन फाइंडिंग्स वर देयर व्हिच वी हैव मिस्ड. And again, treatment, surveillance and prevention is also important in genetic disorders because still now as well, most of the genetic disorders, the treatment is prevention and that is prevention to the next generation. And of course, collaboration with research groups and patient support groups helps a lot, which I'll take you all through different case scenarios. So now I'll discuss certain very good case scenarios which will certainly give you a glance of genetics. This was a 10-year-old girl who was referred to me by my orthopedic colleague. The provisional diagnosis was Marfan syndrome. This girl was having difficulty in walking. We were also suspecting some skeletal issues, skeletal dysplasia. Apart from that, जो Marfan के typical features होते हैं, arachnodactyly, joint laxity was there, wrist sign जो हम लोग देखते हैं, thumb sign, everything was positive. So we also kept a provisional diagnosis of Marfan or Ehlers-Danlos-like syndrome. Now what we did, the family opted for the genetic test, we went for the genetic test. But surprisingly, Marfan syndrome का mutation नहीं आया, mutation आया TGFBR2 नाम के जीन में, जिससे एक syndrome होता है Loeys Dietz syndrome. Frankly, I was also not aware of this syndrome. Then there are certain guidelines to classify the, such variations, and it came out to be likely pathogenic. Now the question should कि सर आपने क्या किया, आपने मरीज का खर्चा करा दिया, टेस्ट करा दिया. Now what the patient is going to have the advantage? I put this gene in OMIM. OMIM is a free database. Then I reviewed the literature, and then I found that this disorder is also a connective tissue disorder like Marfan syndrome, and such patients are known to have sudden arterial aneurysms and aortic dissections are known. This was not evident on my clinical examination. Then what I did, I took the opinion of my cardiology colleague, we went for a CT angio, and we found that aortic root dilatation was detected, and losartan is known to work in such condition. We started the child on losartan. We explained the family regarding the danger signs of aortic dissection, and follow-up CT angio, there is no change in the measurements. And then we are also proceeding for the orthopedic intervention. Now, how genetic testing helped in this condition? It helped us in diagnosing condition and the cardiac issue, which was not evident on clinical examination, and so the child was prevented from a sudden acute cardiac event. Now, case 2, this is very interesting. This was a child who was referred to me by a pediatric neurologist. Generally, जब genetics का दिमाग में आता है, तो हमें लगता है भाई dysmorphism होगा, बच्चा टेढ़ा मेढ़ा होगा, हर बार ऐसा नहीं होता. This child was having involuntary movements, poor growth was there, language delay and hyperactivity. और जब हम लोग रेजिडेंट हैं या फिर हम लोग प्रैक्टिस करते हैं, हम लोग पूछते हैं ना बच्चा देर से रोया था, देन फैमिली हाँ सर देर से रोया था. तो दिस चाइल्ड वाज टैग्ड एज अ केस ऑफ स्पास्टिक सीपी और पोस्ट एचआई सिक्वेली. ही वाज ऑन लिवेरा एंड क्लोबाजाम. As we do for all such cases, we took a detailed history, we drew a pedigree. The child was from a consanguineous family. Head circumference was of course showing severe microcephaly. The child was hyperactive. Poor attention span was there, and most of other examination was normal apart from appendicular spasticity and plantars were extension. We did the routine investigation which was normal. उसके पास एक MRI brain भी था. I would also suggest PGs and residents do review the MRI plates. Radiologically का help लो, सीखो, खुद से भी देखना है. तो but when we reviewed again, we found that subtle myelination abnormalities were there and thinning of corpus callosum was also there. EEG was showing a typical multifocal discharges. Then I also did a plasma amino acid analysis which showed low levels of serine and glycine. Simple एक TMS dried blood spot पे यहाँ भी कर सकते हैं, हर जगह भेज सकते हैं. तो मुझे लगा अच्छा serine glycine blood में कम है. फिर मैंने CSF भी किया, serine and glycine was decreased. Then what? Then we went for the genetic testing, and this child was found to harbor a mutation for a disease called phosphoglycerate dehydrogenase deficiency. This is the ACMG criteria which we follow. Now again, what was the good thing? Then I again reviewed the literature, I found कि भाई इसका treatment तो बहुत easily उपलब्ध है. We started the child on serine and glycine, and but again this will be required lifelong. And the surprising thing is that the cost is very less. 10 kg child, the monthly cost is coming around 1500 to 2000 rupees. And you won't believe, within 3 months of starting of the therapy, there was no seizure recurrence, hyperactivity decreased, and I'm following up this child for last 2 years. Almost अभी मैंने taper करके लिवेरा भी बंद कर दिया, क्लोबाजाम भी बंद कर दिया, बस सेरिन और ग्लाइसिन पे है. So this is the advantage of a genetic testing. And why I want you all to know, because many times we diagnose patients with CP कि भाई birth history delayed है, cerebral palsy है, कुछ नहीं हो सकता. No, especially अगर MRI brain normal है, typical changes birth asphyxia के नहीं है, do think about inborn errors of metabolism. There are some conditions which mimic a CP. जैसे अगर बहुत ज़्यादा spasticity, it can be there in these metabolic disorders like arginase deficiency. Then some conditions in which dystonia can be there, and most of these are inborn errors of metabolism which can be treated with certain modification in diet or certain supplementation. Now case 3, this is also interesting. This child was referred to me with a suspected case of ectodermal dysplasia. इसको बाल नहीं थे, thick skin था, तो typical जो हमारी पहली diagnosis होती है ectodermal dysplasia करके था. We got the genetic test done, and LMNA gene में एक known mutation आया which causes a disorder called Hutchinson-Gilford progeria. वो आपने एक मूवी देखी थी ना अमिताभ बच्चन की, पा करके था, तो सेम डिसऑर्डर. तो भाई ठीक है, हमने जेनेटिक टेस्टिंग कर लिया, आगे क्या? Then I reviewed the literature, I contacted the geneticists worldwide. Then I found that इसकी एक थेरेपी है, lonafarnib therapy, which is a farnesyl transferase inhibitor, and there is an international progeria foundation which is providing this medicine free of cost. Okay, then we started this child on this medication, and then later on 2 more kids were diagnosed, and with the help of Progeria Foundation, these children will get this therapy free of cost throughout their life. So with this case, we learned the technique of collaborating with national and international patient support groups to get medication for our patients. Now case 4, this is also very interesting. This was a child जिसको first 5 years of age में recurrent infection, recurrent otitis media, recurrent chronic diarrhea हो रहा था. हर बार वो acute treatment होता था, and pediatrician used to reassure कि ठीक है, बच्चा बड़ा हो जाएगा, ठीक हो जाएगा, कोई बात नहीं है. But the family was worried every time. But at 5 years of age, the child started showing the typical course features which are seen in certain lysosomal disorders like mucopolysaccharidosis. Okay, then he was having those difficulty in his joint movements and all, and the child was referred to orthopedician. So there are certain red flag signs which when present we should think about mucopolysaccharidosis like coarse facial features. Now why I want you all to know this, because typical coarse features in MPS disorders they generally appear by 4 to 5 years of age. तो हमें अर्ली एज में कैसे पकड़ना है? तो जो ये जनरली एमपीएस के बच्चे होते हैं, इनिशियली दे में प्रेजेंट विथ इंग्वाइनल हर्निया, दे में प्रेजेंट विथ रिकरेंट एक्यूट ओटाइटिस मीडिया इन देयर फर्स्ट ईयर ऑफ लाइफ. सो कीप अ हाई इंडेक्स ऑफ सस्पिशन. एंड व्हाट आई वांट यू ऑल टू लर्न कि अगर नॉर्मल ट्रीटमेंट से कोई बच्चा रिस्पॉन्ड नहीं कर रहा है तो डू थिंक अबाउट दैट केस और वर्कअप कराएं ताकि अर्ली एज में डायग्नोसिस हो. नाउ व्हाई अर्ली एज ऑफ डायग्नोसिस इन एमपीएस इज इंपॉर्टेंट? ये तो स्केलेटल सर्वे किया उस पेशेंट का, जो टिपिकल फीचर्स होते हैं वो उसमें दिखे. Now, why early diagnosis is important? Because most of these disorders have an enzyme replacement therapy. और वो पहली वाली बात नहीं रहेगी कि बहुत महंगा है, मिलेगा नहीं. ESI हॉस्पिटल्स के थ्रू फ्री ऑफ कॉस्ट मिलता है. मेरे कितने पेशेंट्स को मैंने नोएडा में डायग्नोज किया, ESI नोएडा से फ्री में उनकी ERT मिल रही है. Even the government has brought national rare disease policy with which at one time 50 lakhs of money is being given and many children are getting benefit of that. There are 2 enzyme replacement therapy which are approved right now, especially for MPS 2. One is Elaprase and the other is Huntrase. Just a difference of the company. These are weekly intravenous IV infusions. Even in AIMS Patna, few patients are getting. And what is very important is that कि अगर ये therapy late से मिलेगी तो बहुत चीजें irreversible हो जाएंगी, especially the neurological features. So better to diagnose early and start the treatment. Now, especially for residents. स्पॉट डायग्नोसिस कोई बताएगा? ये सारे बच्चे मेरे पास रेफर्ड हुए थे लास्ट ईयर, कोई क्वेरी डाउन सिंड्रोम करके, कोई क्वेरी एमपीएस करके. जी मैम, व्हाई आई हैव केप्ट दिस, आई विल शो. 3 patients were having hypothyroidism, which I feel as a pediatrician, if we are missing hypothyroidism, this is a crime. So beautifully shown in previous presentation, especially last kid was 11 years old. ये तो छोटे थे, especially the second and the fourth child. Why this is a crime? Because we all know कि thyroxine कितना सस्ता इलाज है, ठीक है? And if again we give a stress to newborn screening and we diagnose such patients with hypothyroidism at early age, we start thyroxine supplementation, they are doing quite well. ये वाला तो mucolipidosis था. Why I have kept here is that because mucolipidosis, all the features will be like mucopolysaccharidosis, but the presentation will be in infancy. ये तो पटने की ही फैमिली थी, बट म्यूकोलिपिडोसिस का सैडली ट्रीटमेंट नहीं है, बट अगर फर्स्ट ईयर ऑफ लाइफ में इन्फेंसी में सच फीचर्स आर कमिंग, डू थिंक अबाउट म्यूकोलिपिडोसिस. एंड ऑफ कोर्स एकोंड्रोप्लेशिया इज अ स्केलेटल डिसऑर्डर, शॉर्ट लिम्ब डॉर्फिज्म होती है, इसका भी थेरेपी है. इसका वोसोरिटाइड इंजेक्शन होता है जो 4 इयर्स के बाद लगता है पेशेंट्स को. इवन ग्रोथ हार्मोन हैज बीन ट्राइड. सो राइट नाउ मेनी थेरेपीज आर कमिंग. So universal newborn screening is key to diagnose such disorders. Now this is also very important, something related to pediatric endocrinology. Maturity onset diabetes of the young, we all know. These were two brothers. This child was referred to me by the pediatric endocrinologist who were not showing good response to insulin therapy. फिर इनका हम लोगों ने genetic test किया and we found a mutation in KCNJ11. Okay? So what is important about KCNJ11? इसमें नोन है वर्ल्ड वाइड कि अगर ये जीन में म्यूटेशन है तो इंसुलिन का रिस्पॉन्स नहीं होगा. तो इन दैट केस वी स्टार्टेड द चाइल्ड ऑन सल्फोनिल यूरियाज एंड द चाइल्ड इज डूइंग क्वाइट वेल. सो अगेन हियर जेनेटिक टेस्टिंग हेल्प्ड अस इन डिसाइडिंग द नॉन रिस्पॉन्स टू द थेरेपी. Even in HNF1A. Now case 6, this is also very interesting. This was a 2-month-old female child who was referred to us with typical bilateral CTEV, congenital arthrogryposis, skeletal dysplasia करके इसकी हिस्ट्री थी. We again took the family history. What typical was that the mother of this child was having a very poorly controlled diabetes. हर प्रेगनेंसी में वो GDM था, बहुत HbA1c बढ़ा हुआ था. तो बेसिकली ये क्या था? Maternal HbA1c was 10.4. So this was not a genetic condition. This was a diabetic embryopathy. So again, the learning from this case is that every dysmorphism is not genetic. First rule out the common things, then go for genetic. So history is very important for residents. अगर किसी ने history ली होती तो पता चल जाता कि भाई diabetes है, उसका complication बच्चे में हुआ. So this is my last slide. So what is the take home message? मैंने एक कोड बनाया है CPR PCM. By C I mean clinical diagnosis is always very important. Lab report, genetic report सब secondary है. हमारी clinical diagnosis is important. Pre-test and post-test genetic counseling is very important for patients. For example, आप whole exome लिख रहे हो neurological disorders में, worldwide known है कि diagnostic yield is only 40%. 40% में ही कुछ significant आएगा, 60% में report normal आएगा. अगर आप मरीज को नहीं बताओगे, तो कल को आएगा कि मैडम आपने मेरा 10,000 का जांच करा दिया, कुछ आया नहीं. So that is why counseling is very important, and post-test counseling to explain the results, outcome, and the disorder is also important. Review of the report, do discuss with your colleagues. And again, the option of prenatal testing, PGT. And the cascade testing, I mean testing of the other at-risk family members, especially in cancer. And supplement your NGS reports with segregation analysis. By segregation analysis, I mean कि recessive disorder का mutation है, VUS है, तो एक बार parents में Sanger करा के देख लें segregate कर रहा है कि नहीं. And of course, multidisciplinary management is the key. Do discuss with your colleagues of other departments. And most genetic disorders are incurable, I agree. But don't miss the surveillance and the supportive therapies available. Thank you.
Thank you, Dr. Mayank, for your very nice presentation. And it was very an eye-opener because you can diagnose rare conditions and variants, and it is important in that. But the problem we face is the high cost and non-availability of the testing in the government hospitals. Yeah. So we prescribe, and then when the cost comes to 5,000, 10,000 in that range, then our patients are reluctant to go for it, and then finally...
That will be an issue, ma'am, but if we get certain good projects and funding from the government, we have also done a lot of testing free of cost. So with time, the costs are increasing. Decreasing, sorry.
So thank you, Mayank. It was nice listening to you once again, and you emphasized very important aspects. Genetics has always been very important in pediatrics. The problem lies when we were students, as you told in your last slide, most of them are incurable. So we thought कि क्या फायदा कुछ करने से होना नहीं है. Then our neurology friends, they started exploring genetics. So now 90% of neurology has gone to genetics. You can't make a diagnosis without a genetics except from the small 1 or 2 conditions. Then the nephrologists went for the genetics, and I am a PHO person, pediatric hematology oncology. Our 50% MDS have a genetic basis. Our leukemias we need for translocations every now and then for the treatment protocol. So genetics has now become ingrained in the pediatrics. And one important point you focused, now rare disease that protocol has come, and AIMS Patna, we are the center of excellence for rare diseases. So if you have any condition, any diagnosis, you can send to us. We will be giving the free treatment as per the Government of India mandate, and we have a list of around more than 100 cases we have already registered, including my primary bone marrow failures. They are getting benefited from it. The negative point, what I will tell, so sometimes now our postgraduates, they are not exercising their brains कि ये क्या हो सकता है, सैन फिलिपिनो हो सकता है, MPS हो सकता है, इसमें गॉचर्स क्या क्या करना है, फैब्रिज में क्या होना है. They just go for the वो whole exome sequencing कर लेना है. So that is wrong, and where you have to first point a thing what you are thinking, then you go for it. And then unknown significance. The reports of US makes you nowhere, and you will have to again scratch your head and tell the family, this is still a possibility, this may be further explored. So that's all. Thank you.
Thank you, sir.
Thank you, Dr. Mayank. Very good presentation.
Thank you so much, sir. Thank you so much to chairpersons. And now I request everyone to collect your mementos from the back side of this hall, and then to continue the session and to take the event to its next segment and to discuss on the next topic, that is bleeding disorders in children. So our next topic is going to be, mic ka volume please kam mat kijiye. Excuse me. So our next topic is going to be bleeding disorders in children. And to speak on this topic, Dr. Neha Rastogi would come on the stage. First of all, I'd like to call up on the stage all the chairpersons. So firstly, I'd like to invite Dr. Sanjay Nath Jha, who is a legendary pediatrician and also the recipient of Social Service Award at IAP 2023. And many of us has witnessed how much social work he has done, and we have already told the story of his social work yesterday only. So that was a major reason he received the award of social service in IAP 2023. And also I'd like to invite Dr. Rakesh Kumar, the senior resident of DMCH. So both the chairpersons are requested to kindly sit on the board and to chair this session. And then I'd like to invite our honorable speaker, Dr. Neha Rastogi ma'am, to speak on the topic bleeding disorders in children. So ma'am is already here, and chairpersons are requested to take their respected seats. And then I'd like to request our third chairperson, Dr. Prem Prakash, who is a senior resident at NMCH, Patna. Dr. Prem Prakash, our third chairperson, we would like to request him as well to please join. And we are waiting for our third chairperson to come so that we can. Okay, already we have two of our chairpersons. If the third chairperson comes, we'd like to request him to join if he comes on the time. And then already Dr. Neha Rastogi is here. So I'd like to request both of the chairpersons who are here on stage to give us a briefing about Dr. Neha Rastogi. Thank you so much.
Dr. Neha Rastogi is a senior consultant in Department of Hematology, Oncology and BMT, Medanta. He is fellowship in bone marrow transplantation and leukemia, fellowship in pediatric hemato-oncology and immunology, DNB, pediatrics and DCH. Received certificate of honors in anatomy, pharmacology, forensic medicine, social and preventive medicine and pediatrics during MBBS. passed all examination in first attempt. Thank you.
A very good morning to everyone. Firstly, I want to thank you all for inviting me here. This is my first visit to Darbhanga. Earlier, I used to visit Patna for my OPDs in Patna, but I have never been to anywhere else apart from Patna in Bihar. So thank you, State IAP chapter of Darbhanga for inviting me. So now coming directly to my topic, which is an approach to a bleeding child. So, a child with a bleeding tendency is a very common presentation in pediatrics. जो है कभी बार हमारे पास ओपीडी में ऐसे पेशेंट्स आते हैं जिनको ब्लीडिंग हो रही होती है, तो अब हमारे पास ये एक कंडीशन है कि हम सबसे पहले उसको डायग्नोस करें, तभी हम उसका ट्रीटमेंट करेंगे. इन हेमेटोलॉजी जो डायग्नोसिस इज द इम्पॉर्टेंट पार्ट, क्योंकि फिर अगर एक बार डायग्नोसिस बन गई तो देन ट्रीटमेंट इज नॉट अ वेरी डिफिकल्ट थिंग. So for diagnosis, for approaching such children, we need a detailed history and clinical examination, screening test, and then specific investigations. So before going on to the further slides, let's go back to our medical college days when we used to learn about the mechanism of homeostasis. तो homeostasis कैसे होता है? अगर मान लीजिए मुझे यहाँ एक कट लग जाए, तो how this bleeding is going to stop? It's going to stop by two things. One is platelet, other one is coagulation. For the platelet, when the injury is there, then उस वक्त von Willebrand factor release होगा, वो जाके एंडोथेलियल से चिपकेगा और उसके बाद वहाँ पर प्लेटलेट एडेशन होगा, एक्टिवेशन होगा और वो इनिशियल हीमोस्टेटिक प्लग बनाएगा. That hemostatic plug formation will take about 2 to 5 minutes to form. After that, the coagulation system comes into the play. Coagulation system is important to prevent the late onset bleeding. So in coagulation system, we all know दो चीजें होती हैं. एक is one is intrinsic pathway, other one is extrinsic pathway. Intrinsic pathway में सबसे पहले factor 12 activation होता है, then it activates 11, then 9, and then with the help of 8, it activates 10. In the extrinsic pathway, हमारा केवल factor 7 activation होता है. ये दोनों चीजें समझना क्यों जरूरी है? क्योंकि अगर आपके पास कोई पेशेंट आया, आपने तो केवल पीटी एपीटीटी कराना है, पर उसका इन्फ्रेंस क्या निकालना है? Only those two simple tests can tell us the diagnosis. ठीक है? तो इसीलिए we need to understand this pathway. From the intrinsic pathway, हम जो है PTT से उसको मॉनिटर करते हैं. एक्सट्रिंसिक पाथवे को हम केवल PT से, प्रोथ्रोम्बिक टाइम से मॉनिटर करते हैं. और फिर ये दोनों पाथवे आके एक कॉमन पाथवे को मिलते हैं. जो कॉमन पाथवे है, that comprises of R factor 5, 1, 2 and 10. This is the same depiction in a pictorial form. Surface activation leads to the intrinsic pathway activation, which later on goes to the common pathway. तो इसको पूरे को APTT हमारा टेस्ट करता है. And then we have the tissue thromboplastin, which activates the extrinsic pathway, which comes into the common pathway. ये हमारा PT denote करता है. And then the test which checks that whether fibrinogen से fibrin बनना है या नहीं, वो हम thrombin time से टेस्ट करते हैं. So now coming on to the important clinical clues, which is history and clinical evaluation. Like in other branches in pediatrics, similar in hematology also, history और clinical examination का कोई दूसरा alternative नहीं है. All fancy tests comes later on, just clinical and history is very important. So detailed history, physical examination, laboratory test and bleeding score. अब कैटेगरीज क्या है क्लिनिकल ब्लीडिंग सिवियरिटी की? सो सबसे पहले है एसिम्प्टोमेटिक, नो डॉक्यूमेंटेड ब्लीडिंग एपिसोड. मतलब आपके कोई वो पेशेंट आया, जैसे कि आईटीपी का पेशेंट है, तो प्लेटलेट काउंट इज अबाउट 50,000, बट द चाइल्ड इज नॉट ब्लीडिंग, सो ही कम्स इन द क्लिनिकल कैटेगरी ऑफ एसिम्प्टोमेटिक. देन कम्स द ग्रेड 1 ब्लीडिंग, जहाँ ब्लीडिंग इज वेरी माइल्ड बट इट अकर्स only after trauma or drug intake, which means that there is an inciting insult which leads to bleeding. Grade 2 bleedings are the spontaneous minor bleeds which happens after bruising, ecchymosis, minor wounds, oral cavity bleeding, epistaxis and menorrhagia. तो ये ज़्यादातर जो हमारी grade 2 bleeding है, ये mucous membrane bleedings होती हैं, which are because of the platelet function defects. Grade 3 bleedings are the deep bleedings, like the spontaneous major bleedings, hematomas, hemarthrosis, CNS, GI bleeding, अम्बिलिकल कॉर्ड ब्लीडिंग, ये ज़्यादातर कोगुलेशन फैक्टर डिफेक्ट्स के कारण होती हैं. Once a child comes with the bleeding, then you have to do the bleeding assessment scores. ये हमारा ISTH BAT they have given this assessment score. Now coming again on the history. अब हमें history में से क्या-क्या clues मिल सकते हैं which can help us to make a diagnosis. We have to observe the pattern of bleeding to know what is the cause of bleeding. If there is a persistent bleeding from a single site, अगर किसी का बार बार सिर्फ एक नाक के एक नॉस्ट्रिल से ब्लीड आ रहा है तो देयर माइट बी अ लोकल अंडरलाइंग कॉज फॉर इट. सो फर्स्टली इवेल्युएट फॉर द लोकल कॉज व्हेन यू आर डीलिंग विद अ bleeding from a single site. But if the bleeding is from multiple sites, then you always should think of a systemic cause. Like if there are mucous membrane bleedings, किसी से epistaxis है या excessive spinorrhea है या bleeding from gums है, then the problem lies with the platelets or von Willebrand factor, which comes under the primary hemostasis. But if you are getting bleeding in the deep soft tissues or joints, then you should think of a coagulation factor defect like factor 8 and factor 9 defect. Umbilical stump bleeding is typically seen in factor 13 deficiency. इसके साथ साथ ये हमको प्रोथ्रोम्बिन, factor 10 and fibrinogen deficiency में भी मिलते हैं. Now coming on to the differences in clinical manifestations of the primary hemostatic defects and clotting factor deficiency. प्राइमरी हेमोस्टेटिक डिफेक्ट्स क्या है? प्लेटलेट का डिफेक्ट या वॉन विलीब्रेंट फैक्टर का डिफेक्ट. और कोगुलेशन क्लॉटिंग फैक्टर डेफिशिएंसी है कोगुलेशन सिस्टम का डिफेक्ट. तो सबसे पहले तो वी विल सी द साइट ऑफ ब्लीडिंग. इफ यू आर गेटिंग स्किन एंड म्यूकस मेम्ब्रेन ब्लीडिंग, देन इट इज प्राइमरी हेमोस्टेटिक. बट इफ यू आर गेटिंग डीप ब्लीडिंग्स लाइक मसल्स में ब्लीड है, जॉइंट्स में ब्लीड है, तो ऑलवेज थिंक ऑफ कोगुलेशन फैक्टर. देन कम्स द ब्लीडिंग आफ्टर माइनर कट्स. माइनर कट्स के बाद ब्लीडिंग डिफेक्ट किस में मिलेगा? प्राइमरी में मिलेगा. उसका रीजन क्या है? यहाँ से कट लगा, प्लेटलेट आया, उसने इसको ब्लड बंद कर दिया. अगर प्लेटलेट में ही डिफेक्ट है तो फिर ब्लीडिंग होगा. कोगुलेशन सिस्टम डिफेक्ट में क्या है? कट लगा, पहले प्लेटलेट ने बंद किया, उसको कोगुलेशन की जरूरत ही नहीं है हल्के कट के लिए, इसलिए कोगुलेशन वाले को सिंपल माइनर कट से ब्लीडिंग नहीं होगा, उनको डीप ब्लीड्स होगा. पेटिके विच आर द minute bleedings from the superficial vessels, वो किस में मिलेगा? Obviously platelets में मिलेगा. But deep hemarthrosis or the big ecchymosis you will get in clotting factor deficiency. Similarly, अगर किसी को ट्रॉमा और सर्जरी के बाद ब्लीडिंग होगी, अगर प्लेटलेट डिफेक्ट है तो इमीडिएट होगी, क्योंकि प्लेटलेट शुरू के 2 से 5 मिनट काम करता है और कोगुलेशन उसके बाद काम करता है, तो डेफिनेटली यू विल गेट डिलेड ब्लीडिंग इन केस ऑफ अ क्लॉटिंग फैक्टर डेफिशिएंसी. समटाइम्स व्हाट हैपन कि सर्जन है, उन्होंने डायरेक्टली ऑपरेट कर दिया, उन्होंने उससे पहले उसका पीटीटी नहीं कराया, तो ऑपरेट किया तब तो पेशेंट ठीक रहा, कोई ब्लीडिंग नहीं हुआ, और बाद में 2-3 घंटे बाद एकदम पेशेंट का बीपी ड्रॉप कर गया, क्योंकि पेशेंट को अंडरलाइंग कोगुलेशन डिफेक्ट था जो कि पहले नहीं देखा गया, और इसलिए उसको डिलेड ब्लीडिंग हो गया. सो दिस इज अ स्लाइड विच शोज the first is showing the petechiae, superficial vessel bleeds, which is a characteristic of platelet deficiency. अगर आपको ऐसा कुछ मिल रहा है तो it is going to be a platelet or von Willebrand defect. It is not going to be a clotting factor defect. Second is showing the joint bleeds, which is definitely in a case of clotting factor. Now coming on to the clinical manifestations. तो अगर आप ध्यान से देखेंगे तो आपको कुछ क्लिनिकल सिनेरियोज मिलेंगे और आपके ज़्यादातर पेशेंट्स जो हैं उन्हीं क्लिनिकल सिनेरियोज में फिट हो जाएंगे. लाइक अ सिक चाइल्ड विद फीवर, शॉक, म्यूकोक्यूटेनियस परफ्यूरा और frequently has DIC. सिमिलरली एक छोटा बच्चा है, टॉडलर है, अब उसने चलना शुरू किया है और फिर उसके दोनों घुटनों पे सूजन आ गई है. डायग्नोसिस इज हीमोफीलिया, स्ट्रेट फॉरवर्ड, क्योंकि जब वो चल रहा है तो उसके जॉइंट्स फर्स्ट टाइम एक्सपोज हो रहे हैं ट्रॉमा को एंड ही इज हैविंग ब्लीडिंग इन देम. सिमिलरली अ गर्ल कमिंग विद सीवियर मेनोरेजिया, 90% ऑफ द टाइम्स इट इज वॉन विलीब्रेंड डिजीज. वंस वेल लुकिंग चाइल्ड, कोई दिक्कत नहीं है, बस पेटिके हो रखे हैं, IDP is the diagnosis. But when these petechiae are localized to the buttocks, ankles and feet, then HSP is the diagnosis. Now हिस्ट्री में अब और क्या आएगा? एज एट ऑनसेट. दिस इज ऑल्सो वेरी इंपॉर्टेंट. So if the early age and onset hai, so we are dealing with something which is congenital in origin. If there is delayed development of bleeding later in childhood, then what we are dealing with, either the milder congenital disorder or the second one is acquired problem. Past medical history is also very important. Response to trauma is an excellent screening tool. पहले कभी चोट लगी लेकिन बहुत ब्लीडिंग नहीं हुई, या पहले कभी हमने सर्जरी की, टूथ एक्सट्रैक्शन हुआ पर बहुत ब्लीडिंग नहीं हुई, इट मीन्स दैट द चाइल्ड डजंट हैव एनी अंडरलाइंग ब्लीडिंग डिसऑर्डर. अगर होता तो उस वक्त भी उसको ब्लीडिंग होती. Always inquire about the surgical procedures, serious injuries and fractures, and take a detailed menstrual history where it is applicable. So this is the slide which is showing the acquired bleeding disorders like in overwhelming sepsis, liver disease, malabsorption syndrome, congenital acyanotic and cyanotic heart diseases, and sometimes in leukemia. Next point in history taking is family history. Family history बहुत important है. आधे टाइम आपका डायग्नोसिस फैमिली हिस्ट्री से बन जाएगा. जैसे if a child comes with a history of bleeding in the joint, or say it is a GI bleeding, because अगर joint bleeding है तो डायरेक्टली पता चली गया कि हीमोफीलिया का बहुत चांसेस है. लेकिन अगर GI bleeding के साथ आया और आपने हिस्ट्री ली कि उसके मामा को भी ब्लीडिंग का प्रॉब्लम है, या उसकी मौसी के लड़के को भी ब्लीडिंग का प्रॉब्लम है, या फिर उसके नाना को ब्लीडिंग का डिसऑर्डर था, तो then you get to know that it is an X-linked recessive disorder. And what are the DDs for that? Only two DDs, hemophilia A or hemophilia B. But if you get a history कि जो है ऑटो की, जैसे एक लड़की आई विद मिनोरेजिया, और हिस्ट्री क्या मिल रही है, बच्चे को मिनोरेजिया है बच्ची को, और उसकी मदर को या उसकी नानी को भी हैवी मेंस्ट्रुअल ब्लीड था, या फिर उसकी दादी और उसकी बुआ को भी हैवी मेंस्ट्रुअल ब्लीड था, तो आपको क्या पता चल रहा है दैट इट इज अ ऑटोसोमल डोमिनेंट टाइप्स एंड द चाइल्ड हैज वन वॉल्यूलेंट डिजीज. Most of the other remaining clotting factor deficiencies are the autosomal recessive. Next come a very important history which we usually forget. हम जब history लेते हैं तो हम medications history पूछना भूल जाते हैं. As a pediatricians, since our kids are not on medicines, तो हमको medicine history लेना इतना याद नहीं रहता. If you go to on the adult side, तो adult physicians की बहुत अच्छी history आदत होती है कि वो medicine history ज़रूर लेते हैं, क्योंकि उनके पेशेंट्स हमेशा 8-10 दवाइयों पे रहते ही हैं. So what you have to take is a careful history of medications used should be obtained, including the prescribed medications, over-the-counter drugs and the herbal products. Drugs associated with bleeding diastasis can cause it by the induction of thrombocytopenia or platelet dysfunction. So I have kept this slide to share with you a very interesting case which came to in my practice few years back, about I think 2018 की बात है. So this was a kid who was a 13-14-year-old boy. He was an adopted child of the parents. Parents were little old, they were in their 60s. And they came with this history कि बच्चे को मुंह से खून आता है. It was red-colored fresh blood. The child has already seen many doctors in the town, and when he came to in the emergency in the middle of the night, he was already well investigated. बाहर का CBC नॉर्मल था, प्लेटलेट नॉर्मल था, PT नॉर्मल था, APT नॉर्मल था. उन्होंने उसका जो है बाहर GI वर्कअप भी हो रखा था, चेस्ट वर्कअप भी हो रखा था, ENT वर्कअप भी हो रहा था. मतलब कि ब्रोंकोस्कोपी वाज डन, CT चेस्ट वाज डन, बोथ वर नॉर्मल. This MRI brain with angio has been done to see something कि ब्रेन से कुछ हो रहा हो, वो भी नॉर्मल था. Endoscopy was already done, बाहर वो भी नॉर्मल थी. And they came and the child was really having this blood in the mouth. The parents were really very worried. We admitted the child. We also sent the investigation. CBC normal आया, PT normal आया, APT normal आया. We took the history. My resident took the history. And in the morning when I came, I saw the child was bleeding. और वो एकदम red fresh blood था, यानी कि मुंह से ही आ रहा था, ऐसा नहीं कि कहीं और से आ रहा था. तो history लेते वक्त पहली history ली तो parents didn't said anything. Then I again went after half an hour and then I sat down with them and I took the history again, and at that time they told us कि जो है बच्चा हमारा इकलौता है और बहुत हमने इसको अडॉप्ट किया है, इसलिए बच्चा थोड़ा हमारा हाइपर एक्टिव है. He was taking fluoxetine for hyperkinetic disorder. Fluoxetine sometimes have the side effect of affecting the platelet function. We immediately set the platelet function test. प्लेटलेट फंक्शन टेस्ट का रिजल्ट आने में तो 4 से 5 दिन लगने थे. So what we did, we arranged the SDPC and we have given the SDPC. And you won't believe, immediately after giving the SDPC, the bleeding stopped. And it was like we have given एक दिन छोड़ के फिर हमने दिया, bleeding was completely stopped. We discharged the child and when the report came, it was a bleeding, it was a platelet function defect. अगर आपके पास प्लेटलेट फंक्शन डिफेक्ट के लिए प्लेटलेट फंक्शन चेक करने की सुविधा नहीं है, तभी भी अगर आप देखते हैं कि आपने अपना गूगल पे सर्च किया कि ये दवाई प्लेटलेट डिसफंक्शन कर रही है और आपको पता चल जाता है, तो आप आराम से सिर्फ एसजीपीसी दे सकते हैं एंड यू कैन सेव अ लाइफ. आफ्टर द हिस्ट्री, नेक्स्ट इंपॉर्टेंट थिंग्स इज एग्जामिनेशन. अब एग्जामिनेशन में अब कोई बच्चा आया तो हिस्ट्री तो लेते ही रहेंगे, पर साथ में सबसे पहले हम ये देख लें कि बच्चा स्टेबल है या सिक. पता चले हम हिस्ट्री लेने में इतने मसरूफ हो गए कि बच्चा शॉक से ही मर गया. सो फर्स्टली सी वेदर द चाइल्ड इज स्टेबल और सिक, व्हाट इज द पल्सेस, व्हाट इज द बीपी एंड वेदर द चाइल्ड इज हैविंग एक्टिव ब्लीडिंग. मान लीजिए कोई जीआई ब्लीड करके आया है और उसको एक्टिव ब्लीडिंग चल रही है, तो स्टेबलाइज द चाइल्ड एंड स्टार्ट आईवी फ्लूइड्स. सी वेदर द चाइल्ड हैज bruises, petechiae, joint bleeding, intracranial bleeding. And along with that, also now start thinking the cause. Cause देखने के लिए आपको general examination करना पड़ेगा. If the child is having pallor, it tells you that the bleeding is severe. If the child is having adenopathy, you will understand that उसको कोई systemic disorder है जो केवल platelets को affect नहीं कर रहा है, other चीज़ों को भी affect कर रहा है. You have to see the hepatosplenomegaly to rule out the leukemia. And after this, there comes the investigation. So your investigation will be directed with the thrombocytopenia. For the platelets, you have to see कि whether इनका number कम है या इनकी quality में खराबी है. यानी whether it is the thrombocytopenia or whether it is a platelet function disorder. In coagulation, you have to see कि extrinsic pathway का problem है या intrinsic pathway का problem है. And then comes the other things like collagen vascular disorders, Ehlers-Danlos syndrome. So starting with the initial screening test. So first and the foremost test is complete blood count with a peripheral smear, platelet count and size, prothrombin time and activated partial prothrombin time, APTT. आपके maximum diagnosis इन 4 टेस्ट से बन जाएगी. अगर आपको कभी भी platelet count कम मिलता है, तो just then not focus on the platelet count. You have to see whether the platelet count just alone is decreased or it is decreased with the or increasing with the hemoglobin as well as the TLC. So now we will start discussing the different scenarios which will get after ordering the screening test. तो पहला scenario क्या हो सकता है कि केवल you get the abnormal platelet count but the PT as well as APTT is normal. So how can you get a low platelet count? Firstly, the child is having infections in which dengue is the most common, but others are HIV, CMV, EBV, or the bacterial infections like enteric rickettsia, malaria, fungal, or the child can have a ITP. ITP is one of the common disorders which we pediatricians see. And sometimes autoimmune disorders, अगर बच्चा 2 से 10 साल का है तो ITP is more common. अगर 10 साल के ऊपर तो think of autoimmune disorders like SLE. Peripheral destruction can also lead to the decrease in platelet. And then we can have decreased protection. तो जैसा मैंने पहले कहा कि जब आपके पास एक decreased platelet का बच्चा है तो always see कि दूसरी cell lines का क्या हाल है. क्या उसका HP ठीक है, क्या उसका HP कम है, क्या उसका TLC ठीक है, whether the TLC is decreased, increased or normal. Because you might be dealing with something else and you are focusing just on ITP. So we get a number of referrals from the periphery that the patient was given steroids for ITP and then they end up with us for leukemia. So जो प्राइमरी पीडियाट्रिशियन था उसने देखा प्लेटलेट कम है, बच्चा तो ठीक लग रहा है, तो उसने स्टेरॉइड दे दिया कि आईटीपी है. और उसने नहीं देखा कि टीएलसी जो है 14,000 था, उसमें लिम्फोसाइट्स ज़्यादा थे, न्यूट्रोफिल्स कम थे. इट वाज अ केस ऑफ ल्यूकीमिया. उसने नहीं देखा कि एचबी 8.8 था. सो व्हेन द ल्यूकीमिया स्टार्ट प्रेजेंटिंग, उस वक्त जो है धीरे धीरे एचबी कम होगा और टीएलसी धीरे धीरे बढ़ेगा. एट दैट टाइम यू माइट मिस. सो गिविंग स्टेरॉइड्स in a case of ITP without doing a bone marrow is only justified when the other two cell signs are absolutely normal. If the other two cell lines are not absolutely normal, you cannot give steroids without doing a marrow. Because once you have given the steroids, the diagnosis will be delayed and the prognosis of the child will be worse. Also, अगर आपने सोचा ATP है खाली तो प्लेटलेट कम है, बट हो सकता है बच्चा एप्लास्टिक अनीमिया का हो, उसका HB भी कम है और उसका TLC भी कम है. So if you have given adequate focus to the other two cell lines, then you would have picked up a aplastic anemia early. And nowadays, the prognosis of all these things are good. Next comes the mean platelet volume, which is also important. अगर जो है क्या कहते हैं ITP होता है उसमें bone marrow protection increases and the platelets are released early, so you will get a big platelets. And in viscodeltoid syndrome, you will get small platelets. We will do bone marrow as already told you if you are getting problem in the other two cell lines. Next scenario is APTT prolongation with normal PT and platelet. तो अगर APTT खाली prolong हो रहा है, we know it is extrinsic pathway, we know it is the factor 7 deficiency. Sorry, it is the intrinsic pathway, and we know that it is factor 8, 9, 11, 12 and pre-kallikrein deficiencies. यहाँ पर mixing studies play a role. अगर आपको APTT prolong मिल रहा है, then you have to go for the mixing studies. मिक्सिंग स्टडीज में हम क्या कहते हैं, एक पेशेंट का प्लाज्मा लेते हैं 10 ml प्लाज्मा नॉर्मल लेते हैं, उनको मिक्स करते हैं. God has given us a very huge amount of reserve. Even if we have 50% amount of any factor, we will not have any problem. तो जब हमने 50% पेशेंट का लिया, 50% नॉर्मल लिया, मिक्स किया, तो वो नॉर्मल हो जाएगा. And we will get to know that there is a deficiency of a specific factor. Next scenario is prolongation of both PT and APTT with normal platelet count. अगर PT और APTT दोनों prolonged है, तो we know that it will be something in the common pathway. तो common pathway में हमारा क्या है? Factor 10 है, factor 5 है, factor 2 है, and factor 1 है. इसके अलावा liver disease and vitamin K deficiency also lead to the prolongation of both PT and APTT. Fourth scenario is केवल PT prolonged है. खाली PT prolonged है, तो हमारा जो है फैक्टर 7 डेफिशिएंसी होगा because it is because of the extrinsic pathway. Now there is a scenario कि आपका प्लेटलेट भी कम है, PT भी abnormal है, APTT भी abnormal है, then it is because of the conception coagulopathy, which is DIC. So we can get DIC in a number of conditions. I think you all must be knowing about that. Sixth scenario is कि प्लेटलेट भी नॉर्मल है, PT भी नॉर्मल है और APTT भी नॉर्मल है. तो फिर क्या हो सकता है? It can be a von Willebrand disease, it can be a factor 13 deficiency, it can be a platelet function defect, like जो मैंने केस आपको बताया था, collagen vascular disorder, especially Ehlers-Danlos syndrome, vascular malformations, non-accidental trauma, HSP, scurvy. इसके लिए you can do the next level test. Now coming on to the platelet function. Normally, platelet don't adhere to the vessel walls. If we see that इसमें एक कहीं पर vessel wall injury हुई, तो platelet जाके वहाँ पर adhere करने लगी, and वहाँ पर adhere करने के बाद aggregation हुआ और release हुआ. So, platelet adhere करने के लिए they need the von Willebrand factor, and on the platelet there is GP1B factor. So, if von Willebrand factor is not there, the child will get the von Willebrand disease. But if there is a problem with the GP1B receptor, then it will be a Bernard-Schwaller syndrome. So, in platelet aggregation, the granules will release ATP, and you will get the release defects. So, this is my last slide. So what is the take-home message? That you have to do a detailed clinical history, and then you have to order for a screening test, which is CBC, peripheral smear, and PT, APTT, and depending on what you are getting in the result, you will make a diagnosis. If you are having a thrombocytopenia, you will think of ITP and other disorders like leukemia or aplastic anemia, if there is problem in other cell lines also. But if you have only PT abnormality and normal APTT, you will think of factor 7 deficiency. If normal PT but abnormal APTT, you will think of hemophilia. And if both PT APTT is abnormal, then think of liver disease, vitamin K deficiency, as well as common pathway deficiency. And if everything is normal, then think of something rare like factor 13 deficiency or von Willebrand disease. Okay. And at last, a big thanks to all of you for inviting me here. Thank you so much.
हेलो थैंक यू मॉम इस खूबसूरत प्रस्तुति के लिए बहुत बहुत बधाई. When the subject is tough and the expression is simple, the subject itself becomes very simple. Thank you very much.
Very nice presentation by Dr. Neha Rastogi. She explains in a simple way, and clinical history, family history, and screening is the main important tool to diagnose bleeding disorder in children. Thank you.
Thank you, sir.
Well said by Dr. Neha Rastogi, ma'am. Thank you, ma'am.
Thank you so much. Thank you.
Thank you so much, Neha ma'am. Thank you so much to all the chairpersons. Now I request all of you to please collect your mementos from the rear side of this hall. And let's now move to the next topic, which is guest lecture on diabetic ketoacidosis and its management. So first of all, I'd like to invite all the chairpersons to chair this session. First of all, I'd like to invite Dr. Vijay Kumar Singh, who is a legendary pediatrician at Darbhanga. और हम लोग 1 मिनट का ब्रेक लेना चाहेंगे टू अरेंज.
At this moment, we are going to deliver the B.N. Das Gupta oration, and for that, I would like to invite our chairpersons, Dr. K.P. Pandey, sir. Please come on the dais. A.K. Pandey, sorry, A.K. Pandey, sir. A.K. Pandey, sir. Sorry. उन नाम देखो और डॉक्टर गुलवारा का हाँ and Dr. T.P. Golwara, sir. ये वो गलती ठीक 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 है ठीक कोई बात. Now I will like to invite Dr. Arun Shah, sir, to come on the dais for delivering this oration. Before that, I will like that Dr. K.P. sir, Dr. K.P. Pandey, sir, will. Sorry, A.K. Pandey. Actually, sir, हमारे यहाँ ऑर्थोपेडिक्स के हेड थे, उनका नाम हमेशा माथे में आ जाता है. Dr. A.K. Pandey will say something about Dr. V.N. Das Gupta. Sir, please come on the dais.
Talking about late Professor V.N. Das Gupta, it's a great honor for me. He was my examiner in DCH in 1969. And known for his extraordinary competence and skill as super bedside clinical teacher and magic-like treatment, Dr. V.N. Das Gupta was born on 19th December 1919. Did his MBBS in 43, MD Medicine, and later MD Pediatrics, 47 onwards, from Prince of Wales Medical College, Patna, now known as Patna Medical College. And then completed his DCH and member of Royal College of Physicians in 1950. He joined Darbhanga Medical College as associate professor in 1951 and became head of the Department of Pediatrics in 1964.
Hello.
And principal of DMC in 1973. He retired from his job in 76 and served humanity as free medical practitioner. Most probably all the senior doctors know that he not only practiced pediatrics, but was also known as a great clinician and general practitioner in general medicine also. He was honored as a professor emeritus in the Department of Pediatrics in June 1977 for his invaluable contribution in pediatrics and extraordinary treatments. Talents, WHO awarded him fellowship related to maternity and child health projects as early as 1951. During his academic tenure, he published many journals in 69 and onwards. He was honored as Professor Emeritus, as I told you. For a doctor, the ultimate accolade are not just citations and degrees, but his love for common man, which inspires many achievers. One rare achiever of such magnitude was Professor B.N. Gapdusta. He left for heavenly abode in 1992. We hope he is still blessing us from heaven on the occasion of this PEDICON 2023. May his soul rest in peace. Recognizing this noble pediatrician, scientist, and social reformer, and a great teacher, IAP Bihar started this B.N. Das Gupta oration in 2011 PEDICON at Gaya. And we take all these orations in his memory as our homage to the great person. Thank you.
Pay a floral tribute to Dr. B.N. Das Gupta, and we shall stand after that.
आप रहेंगे ना सर, कैसे बात कर रहे हैं?
To Dr. V.N. Das Gupta. Now I will like that Dr. Golwara will speak something about Dr. Arun Shah. Sir, please.
Dr. Arun Shah, MD, DSH, FRCP, FIAP, FNNF, FIMA, SA. Executive Body Member of Central IAP 2012 and 2018. President IAP Bihar 2018. He is well-known pediatrician and social worker of Muzaffarpur. Well-known in city, everybody known as a बच्चा का डॉक्टर है और ये गरीबों के बीच अपना स्थान बनाए हुए हैं. Thanks.
Thank you, sir. Now the stage is Dr. Arun Shah, and he will say so many beautiful things to us. Thank you, sir. Please start, sir.
Thank you very much for the kind words, sir. It's indeed a matter of great pleasure, privilege, and honor for me to give a oration in name of my teacher. I joined this alma mater in 1972, and at that time, Dr. Dasgupta used to be our teacher. He used to be our teacher. He was an emeritus professor at that time, and we used to go and attend his clinical classes. He was the one guy in Bihar where the patients from outside Bihar used to come for medical checkup for the children, not only children, for the adults as well. So I had the honor of understanding the ABCD of pediatrics at the bedside, in fact. Das Gupta Sahab was known for his spot diagnosis, clinical spot diagnosis. I remember when he showed that this is a case of Down syndrome, this is a case of hypothyroidism, this is a case of ectodermal dysplasia. We never heard of that in 74, 75. My interest in pediatrics definitely grew when I came in contact with him. So after that, I never looked back. So I'm really indeed very much happy, very pleased to talk about a topic, antimicrobial resistance. Are we heading towards a disaster? I had prepared 50, 60 slides, but I see that most of the people hardly look at the slides. So I decided to go ex tempo. First of all, sitting in front of me, the giants in the pediatrics, stalwarts of pediatrics, Professor S.A. Krishna sir, Dr. Neelam Verma, Dr. Alka, Dr. C.V. Chandra Mohan, Dr. Vijay Kumar, all of the colleagues, the PG students, my even practicing pediatricians. I'm happy that out of what जो भी लोग आप लोग आए हैं, कम से कम हमें सुनेंगे, and I might hope that I could be able to change the prescription behavior of few of the practicing pediatricians after I have finished my talk. In 2014, under the Presidential Action Plan, rational antimicrobial therapy was launched by Dr. Vijay Yavle, and I used to be the resource person in preparing and drafting the what is the rationale behind it. So let me begin my talk with a story. My brother, one of my youngest brother, who used to stay in Jaipur, he had developed infections. He developed infections, fever, and difficulty in taking breathings. He was brought to the Fortis Hospital in Jaipur. He was diagnosed to be a case of pneumonia. He was given the first line of drug like ceftriaxone, later ceftazidime, and amoxiclavinic acid. He didn't respond. His clinical condition continued to worsen. Then he was given morapenam group of drugs and sent a sample of bronchoalveolar lavage for culture and sensitivity. Why he's not even responding to the, at that time, morapenam used to be one of the most effective antibacterial drug, antibiotic. But He didn't respond even to Morapina. And then, when the culture report come, everybody was shocked because I was in touch with the treating doctor who was looking after him in the ICU. The culture report showed Klebsiella resistant to all antibiotics. Klebsiella pneumoniae resistant to all antibiotics. And finally, my brother succumbed. This was my first case of pan-resistant bacteria in my family who became a victim of antimicrobial resistance. We'll talk under these headings. We'll talk first the history of antibiotics. Do you know that before 1930s there used to be pre-antibiotic era? There was never any antibiotic. People used to die of septicemia, meningitis, pneumonia, tuberculosis, cholera, plague. There was no antibiotic. In 30s, sulfonamide in the form of sulfanilamide was launched. It has a limited antibacterial properties. In 1928, the greatest breakthrough came when Alexander Fleming, it was a chance finding for him. He was a bacteriologist. He was growing staph colonies in the petri dish, which was contaminated by the mold. And next day, they observed that the staph colonies were eliminated or killed by these molds. And then he named these molds as penicillin. One of the greatest discovery of the last century, saving millions of lives from dying from the bacterial infections. Alexander Fleming got the Nobel Prize in 1945, and while he was receiving the Nobel Prize, he warned the world that indiscriminate, injudicious, and thoughtless use of this penicillin might lead to the emergence of resistance against the penicillin, and he was right in his prophecy. In less than 5 years, the penicillin started showing the resistance. Then the pharma company jumped in, and series of antibiotics, starting from beta-lactam antibiotics, tetracycline, chloramphenicol, macrolides, quinolone group of drugs, cephalosporin from first to fourth generation. And pharma company were very happy that they are doing a very good business because, and doctors were also very happy that after all, we are having one alternative after another alternative. So we are not lagging behind the resistance. But last resort antibiotic when you came into market, like last resort means reserve antibiotic against the nightmare bacteria, those were the vancomycin, linezolid, colistin, daptomycin, tigecycline. As per the All India Institute of Medical Science, in a recent survey over all the ICUs, across all the ICUs of India, they observed that more than 40% of bugs have become resistant to even the last resort antibiotics. Isn't it frightening? Isn't it scary? So, our journey from penicillin to tigecycline and daptomycin. So, the golden era of antibiotic was till the last decade of the last century. And my brother was not the only victim. As per the estimate of WHO, every day 3,000 people are dying of AMR. Every day. That comes to about 5 jet planes carrying 600 travelers crashing every day, but there is no news. Every day more than 3,000. That comes to about 12.5 lakhs in a recent report in the 2009. And it is expected that by the end of 2050, 1 million people will die of AMR, more than cancer and road accident combined together. So we had reached at a stage when we were dealing with the superbugs. Even the last resort or last reserve antibiotics were not working in many cases. In India, we do not have proper statistics, but as far as to the best of my knowledge, more than 50,000 people in the Europe and America are dying every year because despite that most of them, millions are getting infected with the resistance. But more than 50,000, and it is growing up. There is an alarming rise in the rate of consumption of antibiotics, proportionate to the rate in the rise of the resistance against the antibiotics, and inversely proportional to the decline in the number of antibiotics being discovered. In last 2 decades, only 4 or 5 molecules have been discovered by the pharma company. Why? They have stopped investing a single penny because it's not a profit-making propositions. It's not because the antibiotic which is discovered by after spending about say billions or millions of dollars pumped to find a new molecule, they become resistant sooner or later. So they thought it is better to switch over to those drugs like making a drugs for the cholesterol, for the hypertension, for the blood pressure, for the diabetes, for the anxiety, for the depressions. So that patient used to take these drugs for their whole life. So most of the pharma company have stopped investing, and they are not investing. This is really a serious matter. On one hand, there is alarming rise in the use of antibiotics, alarming rise in the rate of resistance, but there is a decline in the discovery of the new antibiotics. So let's talk about what are superbugs, how on the earth the superbugs evolved. Superbugs evolved because based on the Darwin's theory of evolution. Since ages, there has been a battle between bugs and human beings. Bugs are much, much, much older than us. They knew how to survive. And they knew how to survive even in the hostile environment by developing the genetic mutations. They developed the genetic mutations, genetic genes, they transfer the genetic genes to the other bugs, not only to other bugs, but also to sensitive bacteria as well. By the process of transduction, transformation, and conjugation. And they developed the biochemical mechanism to just inhibit or to kill or just to escape the antibacterial effects by either not allowing the bacteria for the uptake, by efflux pump, by releasing the enzymes like beta-lactamase, by altering the target sites. So they are smarter than us. So these superbugs evolved because of the most indiscriminate use of antibiotics, because every time a person, if I take antibiotic unnecessarily in case of viral infections, what happens? That this antibiotic will kill all the sensitive bacteria, and one resistant bacteria, because that have developed out of, we call it a intrinsic natural phenomena. So that facilitates the growth of the resistant strains due to evolution and selective pressure. This is a sorry state of affairs that we finally have come to a stage when then superbugs are all around us. It's fortunate that none of us are getting infected right now, but what will happen if one of us gets super infected with the superbugs, and it shows that none of the antibiotics is working. There are two very important stories related to superbugs. One is the KPC factor. In 2000, Center for Disease Control, Atlanta, USA, gave a news that in North Carolina, a patient has been identified with the KPC factor. What is KPC? Klebsiella pneumoniae carbamidase producing organism that was the enterobacterials, and that was resistant to all the antibiotics except the colistin. It gradually spread to the other part of the country. In 2019, a Swedish person got sick in India. He was given the best antibiotic available there, but he didn't respond. He was flown to Stockholm. He was admitted. He was investigated, and he was found to have NDM. NDM, that means New Delhi metallo-beta-lactamase producing Enterobacteriaceae, that was again the Klebsiella. So NDM traveled from New Delhi to, gradually traveled to the other part of the world also. So you can see that once I develop a resistant bacteria, I have the capacity to spread in the community, to you, to community, and that resistant genes can travel across the world, because travel has become so much easy nowadays. Who is responsible for this sorry state of affairs? What could be the cause? I think all of us, all the stakeholders, the practitioners, pediatricians, practitioners, public, policymakers, government, and pharma company, aggressive marketing of the pharma company, all of them are responsible for it. We misuse the antibiotics like anything after the discovery of penicillin. We started using in antibiotics when it was not necessary at all. 20 to 30% of antibiotics, for your knowledge, is used in the humans. But 70%, almost close to 70%, are used in animals husbandry, in agriculture, not to treat the infection, but as a growth factor, in subtherapeutic dose. And that facilitates the emergence of antimicrobial resistance, that is superbugs. So this is the reason how the responsibility goes, and definitely in India there is no accountability, no answerability. Any Tom, Dick and Harry can buy, prescribe, and self-medicate. You can go into the market, can buy even the colistin, morapinam. I mean, it is such a sorry state of affairs, which is not true in USA and Europe. You cannot get an antibiotic without a valid prescription of a practitioner. In Middle East, I have been told that you cannot prescribe an antibiotic unless you consult an infectious disease specialist for the reason why you are prescribing antibiotics. You need to give evidence, whether clinical evidence, hematological evidence, bacteriological evidence, or even the radiological evidence, and that justifies the use of antibiotics. Then one can go ahead. But in India, there's nothing like that. Even the chemist decides which antibiotic has to give. Rural practitioner decide, because I personally believe that we doctors, we super specialists and super specialists have been trained setter. We have been trained setter for misusing antibiotics. No wonder when I used to go to the villages and I used to just explain to the rural practitioner, the quacks, that you shouldn't describe the antibiotics, you shouldn't use the antibiotics. They used to say that कि आपके यहाँ तो बड़े-बड़े डॉक्टर साहब सबको ही लिखते हैं. मैंने कहा यही तो मैं बताने आया हूँ कि आपको नहीं लिखना है. Because most of the febrile diseases are self-limiting. Most of the febrile diseases are viral in nature. They don't require antibiotics, especially in the immunocompetent persons. When now everybody is wondering that, as I said about, that why not pharma company is coming with the new antibiotics. I told you that because it's not a profit-making proposition, so they have stopped making it. So since last 2 decades, not more than 5 molecules have been discovered. And I don't know what is going to happen in the future. So, friends, what could be the consequences? Consequences of antimicrobial resistance is disastrous. If you talk about, the infection will be harder to treat. There will be severe infections. There will the infection will be resistant and spread. There will be prolonged hospitalization, and there are number of deaths attributed to the AMR. So, the most serious consequences is that the patient which we are treating and doesn't respond to the antibiotics means we are dealing with a most likely pan-resistant bacteria. You are giving the best antibiotic, but patient is not responding to infections. And unfortunately, we do not have the microbiological facility everywhere. So without knowing that patient succumbed, but I given my best, but patient didn't survive. Second reason is that the disastrous consequences is that the modern science, if you talk about modern science, say about cancer therapy and chemotherapy, then surgery, then organ transplantations shall not be possible. They are possible only because they are given the umbrella of antibiotic coverage. It is said that this proper antibiotic coverage in these cases reduces the incidence of infection to less than 2%. But imagine if the antimicrobial resistance appears, then without proper antibiotic coverage, the risk would be 40 to 50%. 40 to 50% increase in the death. And logistically, it will not be possible to go ahead with the chemotherapy or surgery or organ transplantation. We are still feeling very safe because we do have a very proper antibiotics. So, the consequences, the economic consequences is also too big. Economic consequences by WHO has been estimated that by the end of the 2050, there will be GDP reduction by 5%. Trillions of dollars will be lost. India and China, country like India and China will be the worst affected. When the GDP, we are thinking of fastest economy in the world. But what will happen that the patient will start dying of the antimicrobial resistance? When 1 crore, 10 million people will die by the end of the 1950. But it is really scary and frightening. There will be tremendous manpower loss. There will be reduction in the farming output also because of the antimicrobial resistance. So, it is really very scary to think that if we have entered in the post-antibiotic era, then we have no treatment options. Still, we as a practitioner deal in our daily office practice 70 to 80% cases of infectious disease, out of which most cases are viral in nature. But 70% of us prescribe antibiotics in day 1, day 2, day 3, without seeing at the patient, without looking at the appearance of the child, without taking his proper history, without doing the proper physical examination, that yes, it could be viral. It's so obvious. IAP has drafted new guidelines that how can you make a difference between viral infections and bacterial infections. Clinically, you can distinguish if you are very careful. You do not have to go for the PCR and bacterial culture. Largest number of cases can be diagnosed clinically, even with the limited resources. But we don't have time. medical science or medical practice is an art and science, not an Olympic race. That way I have to see about 100 cases every day, 150 cases every day. Yes, there are doctors in my city who are seeing about 150, 200 cases every day. How can they justify the use of antibiotics? They don't have time. Before the patient completes his symptoms, he already has completed his prescription. So we have been greatest guilty. We have been the trendsetter. The specialists, the super specialists, the medical college professors, I'm sorry to say, we didn't take any responsibility on us that what we are doing, because what we write, the juniors follow. What the juniors follow, the rural practitioners in the villages, they follow. Chemists follow. So, what can we do? How we can we, I said, sorry, before that, that doesn't mean that undermines the importance of antibiotics. Yes, there are definite indications of antibiotics, which have been drafted in 2014 in National Antibiotic Therapy. Still it is available on the online. That there is a definite indication of antibiotics in 10 to 15% of cases in febrile conditions, like preemptive, like definitive therapy, preemptive therapy, empirical therapy, and chemoprophylactic therapy. Once you know that, yes, life is in danger, we are dealing with a life-threatening bacterial infections, but we need to know whether the child is sick or not, sick-looking, has a hemorrhagic spots. It could be a case of meningococcal septicemia. When you look at the tonsil, it is a acute tonsillitis. There is a focus of infections. There is a bacillary deficiency. So, definite indications have already been drafted in the IAP, but I can see in the last 10-15 years there have been large number of CMEs without having any impressive impact on the prescribers. Because the study shows that there is a definitely increase in the uses. India is one of the leading countries in the world to use the antibiotic most injudiciously. Now the $1 million question is, can we turn the tide? The tide of antimicrobial resistance? Can we stop or diffuse the, time bomb from exploding? Yes, to some extent, we can. Sir, Dr. Ashok sir, please. Can we turn the tide? Yes, we can turn the tide. How can we turn the tide? How can we diffuse the time bomb from explosion? We need to be we need to have a self-introspection. We need to be judicious. We need to have proper mindset. We need to have change in the prescription behavior. We need to have infection control practices. We need to promote the health by proper nutrition, sanitation, hygiene, and vaccination. We need to have active surveillance system so that we could be able to trace out the emerging strains like NDM, which was found in the sewerage of New Delhi. We need to have rapid diagnostic tools to make a distinction between bacterial and viral infection at the point of care. Right now we do have, like bacterial culture and PCR, but we need much faster so that we can make a difference that no, this is a viral infection. But as I said before, that despite the limited resources, as clinicians we can make a large difference. We can make a clinical diagnosis of viral fever in large number of cases with explanation to the patient regarding the danger signs. Yes. What I do, what I'm saying, I do practice. I'm not only preaching, I do practice. Most of my patients do not get antibiotics. I see the patient thoroughly. I check the patient. I tell them, explain them. Most likely it is a viral. Most likely it is self-limiting. I give paracetamol if necessary. I tell them that to keep the child on proper nutrition, hydration. And after 4 to 5 days, most of them come back saying my child is all right. Yes, with red flag sign, like if the child is deteriorating, if there is a clinical worsening of the conditions like tachypnea or respiratory distress or high-grade temperatures which is not perceived, if child is having persistent vomiting, abdominal distension, these are the red flag signs to be explained. And nothing, I tell you, if you do this in your practice, you shall be able to cut down the use of antibiotics. Give time. You need to have time and patience. You need to understand the disastrous implications of antimicrobial resistance in time to come. So we need to have antibiotic stewardship. What is meant by antibiotic stewardship is the optimizing the use of antibiotics with the best outcome, limiting the toxicity and limiting and avoiding the toxicity. Antibiotic stewardship means you are giving antibiotic to the right person in the right dose, in the right route, right duration, with the right documentation as well. We need funding for awareness program, for surveillance, for the research. We need to give incentive to the pharma company for the new molecule. We need to look for alternative to antibiotics. Yes, there are a lot of work going on right now in the world in form of bacteriophage, lysine, probiotics. Could they be alternative to antibiotics? Still, the research is in the infantile stage. But people are thinking about how long we shall combat this antimicrobial resistance when we are out of the proper antibiotics. So, friends, again, what as a practitioner or what as a clinician, despite that we are using antibiotics are misused in 20% of the human populations, at least onus of responsibility is on clinicians, on all of us, to save the currently available antibiotics from being ineffective by judicious use of antibiotics. It is said that if you think before you ink. You need to be very, very careful while prescribing antibiotics because antibiotics prescription is not going to affect only one person. It is going to affect the entire community, entire globe in form of emergence of superbug. And we are morally responsible for it. So, friends, before I conclude, these are the take-home messages I would like to tell you. I would like to share you that there is no doubt, it cannot be denied that discovery of antibiotics was one of the greatest breakthrough in the medical science of the last century, which saved millions of lives from the bacterial infections. But emergence of the antimicrobial resistance continues to be one of the greatest threat to the mankind, risking the millions of lives from dying with the MDR infections. WHO has termed this antimicrobial resistance as one of the biggest global threat to the mankind. And for that reasons, they have been celebrating the whole 1 week every year from 18th November to 24th week, 18th November to 24th November to just raise the awareness among the public. Now, WHO is asking that don't go to doctors only, go to the public. Go to the public, explain them, ask and tell them that they need to ask their doctors why you have prescribed antibiotics. Yes? So, WHO past Director General Margaret Chan has termed that if we enter the post-antibiotic era, it is going to be end of the modern science, and we'll go back in the pre-antibiotic era when a minor cut injury causing cellulitis, streptococcal sore throat will be fatal. So, friends, if we are using antibiotic, if we are using antibiotic indiscriminately, we must think twice, because if there is no care today, there will be no cure tomorrow. If there is no care today to save these currently available antibiotics, there will be no cure tomorrow. Simple advice, simple tips. You can make a distinction between viral and bacterial infection, which are largest number of the cases in the febrile illness are viral in nature, which do not require antibiotics. Most of our colleagues think that antibiotics will modify the course of viral infection. This is not true. Antibiotics will prevent the occurrence of secondary bacterial infection. It is not true in immunocompetent persons. Antibiotics will harm the patient. Not only with the emergence of AMR, but also they have the inherent toxicity. As you know that antibiotic-associated diarrhea occurs in as many as 20% of cases. And the most serious complication is pseudomembranous colitis, toxic megacolon. People usually die of that. Apart from anaphylaxis, starting from the anaphylaxis to the neurotoxicity, nephrotoxicity, renal toxicity, and so many syndromes like Stevens-Johnson syndrome with the use of antibiotics. People have died because of the drugs side effects. So friends, I conclude my talk with a message to all the emerging pediatricians, PGA students, my colleagues, that let us save these antibiotics by the prudent use. Save these antibiotics by the prudent use of in order to save the mankind from disaster. Thank you so much.
Thank you, Dr. Shah. You are known as a great crusader for rational antibiotic therapy, not only among the clinicians, among the teachers, but also on the social media. And he was one of the most appropriate person to deliver his oration on this topic. Thank you. Thank you very much.
Thank you so much, sir.
ठीक था sir.
And in that way, we have completed the oration.
Sir, ठीक था sir. Huh?
And then I'd like to request all the chairpersons and also the speaker to accept the felicitation from our side. Thank you so much for joining, and thank you so much for your valuable time. Thank you so much for enlightening us with a shower of knowledge. Our next topic is going to be diabetic ketoacidosis, and thank you so much, everyone.